Good afternoon, everyone. Welcome to our neuromuscular session this afternoon. Thanks for taking the time to be today with us in Friday afternoon. Hope you're enjoying the conference as much as I'm doing. I would like to say thanks to Dr. Patterson and Dr. Birney for organizing this meeting and the rest of the organizing team to give us this virtual space today. The main goal of today's session will be discuss diagnosis and treatment of cardiovascular aspects that are always challenging population such as neuromuscular disease patients. For the session today, we're going to divide it in two. First part is going to be some case presentations followed by some guidelines review. We have two big guidelines, one for heart failure and the other one for arrhythmias that was released last year. And the second part will be a few special guests presenting. So I will start with our presenting our first speaker, that is going to be Dr. Sadek. Dr. Sadek is a very well-trained and very talented electrophysiologist and cardiologist, currently working at Southlake Regional Hospital. He's also a very busy researcher, and maybe part of the reason why I was involved in the neuromuscular disease since a few years ago. He organized the journal club for the fellows while he was working here in Ottawa as an EP program director. And during that meeting, we recognized the huge vacuum in knowledge and the lack of organized approach or standardized approach that we have to these patients. So we decided to create a new neuromuscular clinic at the Heart Institute. So thank you very much for being with us today, Dr. Sadek. It's a pleasure to have you.
Thank you, Dr. Klein and Dr. Ghosh, for asking me to speak at this conference. Very happy to. And this is a case that we all managed together that brought up some questions, and hopefully it'll be useful to talk about it. It's a 69-year-old gentleman referred for pacemaker failure, and I was actually on service at the time when he presented to hospital. He had a past medical history of muscular dystrophy type 2, diagnosed 10 years prior by genetic testing. He has muscle weakness and uses a cane, but is able to carry out independent activities. He also has early bilateral cataracts and hearing aids, which is also typical of muscular dystrophy type 2. He had conduction system disease, and in 2005, he developed complete heart block and had a dual-chamber pacemaker inserted. And in 2012, it was noted that his RV threshold was increasing, so there was some failure of the RV lead, and a new lead was put in at the same time as a battery change. He also has type 2 diabetes and factor V Leiden with the DVT in 2018. When he came to hospital, he had presented with syncope that sounded cardiac in nature. And when we checked his device, he actually had evidence of lead fractures. So his RV lead was failing again. And you could see a lot of artifact during device interrogation just by moving around the device. So now he's had two leads fail on him, unfortunately. This is his chest X-ray. So you see, here's the device. There's a right atrial lead. There's the old right ventricular lead in the apex, and there's the newer right ventricular lead, which has also failed. So he has 3 leads already, and he's going to have a new lead put in to prevent further episodes of syncope. This is ECG, and as you can see, the pacemaker was still working most of the time. It's only when there is oversensing that it would cause pauses and he would faint. But he was pacing in the atrium and the QRS, and this is RV apical pacing, which gives you a wide QRS that looks like a left bundle. He had an echocardiogram that showed global LV dysfunction with an ejection fraction of 35%, and this was not noted prior on his previous echocardiograms. These are the guidelines which my colleagues are going to go through in more detail than myself. But one of the tables that compares different types of muscular dystrophies It's noted that patients with DM2 do get conduction system abnormalities, ventricular arrhythmias, and atrial arrhythmias, but it's rare for them to get cardiomyopathy due to the genetics of muscular dystrophy. And the questions regarding this case is, should we remove his old leads or simply add a new lead? Because now he has multiple non-functioning leads in his heart. And a lot of these patients will have these same issues. They get the leads at a young age, and leads don't last forever. And you end up having to come up with a decision: remove the old lead or leave it in and just add a new one. Should we offer this patient a defibrillator given his low ejection fraction? Why does he have LV dysfunction to begin with? And should we offer this patient a CRT or alternative pacing modality? Regarding the first question about whether we should remove the old leads or simply add a new one, we've looked at this question in our patients in Ottawa, and we examined patients who've had lead fractures or lead advisories and had new leads put in, and we followed them over years. And the summary of the study was that leaving old leads in place is actually okay. These patients do very well. Very few of them get infected, less than 2%. And most of them tolerate the old lead with no thrombus complications or no complications related to the old lead at all. Whereas removing the lead using laser lead extraction does carry a risk. It's a big procedure. There's a risk of damaging the heart or damaging the vessels and or damaging the tricuspid valve, and the risk outweighs just leaving the lead in place. So given that, we have been leaving those leads in place as part of our strategy. Should we offer this patient a defibrillator given a low EF? And, if you look at the guidelines in patients with Duchenne muscular dystrophy, there's actually they're actually at higher risk of sudden death from ventricular arrhythmias, even if the ejection fraction is normal. So in our particular patient, he has conduction system disease, he has complete heart block, and you could potentially offer him a defibrillator even if his ejection fraction is normal. It's a 2B indication in the guidelines. However, these patients do have muscle weakness, and sometimes the goals of care do not include prevention of sudden death. And it's a very morbid conversation, but we have to have it with all of our patients. The defibrillator portion of the device will not improve the quality of life. That's for the pacemaker portion. Do they want to be saved if they were to have a cardiac arrest? And that really depends on the clinical picture and their quality of life and their prognosis. So it's a very important conversation to have, and some patients may not want to have the capacity of sudden death prevention. In this particular patient, we had that conversation, and he did not want a defibrillator. However, he did want his pacemaker changed, of course, given syncope and the effect of that on his quality of life. Why does this patient have LV dysfunction? And that's a very important question. And as we said, it's rare to develop cardiomyopathy in patients with DM2. And he actually was investigated, and he had a CTA that showed normal coronaries, so there was no coronary disease responsible. One entity to always think about is pacing-induced cardiomyopathy. And in patients who have chronic right ventricular pacing, they can develop ventricular dyssynchrony. And the reason for that is when we pace through the muscle of the right ventricle, the conduction through the heart is slow, and usually starts with the septum, followed by the lateral wall. So you get a wide QRS complex, and this dyssynchrony does actually lead to heart failure in some patients. It's not a large portion of patients, but it does happen in some of our patients. And a recent paper looked at the risk factors for pacing-induced cardiomyopathy, and our patient actually has multiple of these risk factors: being male, being older, having an RV pacing percentage that's high, and our patient was pacing all the time, also puts you at risk. And the QRS duration during pacing also puts you at risk. And this patient's QRS duration was almost 200 milliseconds. It was quite long. So it tells you that there's a lot of delay in conduction when pacing the right ventricle. So the most likely culprit we thought was chronic pacing. And if we simply put a right ventricular lead back in the same place, this will simply continue to progress. So in this case, we have multiple choices. We can either offer a patient a CRT pacemaker, where we pace the left ventricle to the coronary sinus, or pace and the RV at the same time. So we're pacing from multiple sites. or an alternative pacing modality. And one of the new pacing modalities we're doing is physiologic pacing, where we actually put the leads deep in the septum and try to capture the conduction system, which is called either his bundle pacing or left bundle pacing. So you can either put a lead in the septum, try to capture the conduction and mimic what a normal conduction would be like, or you could put a CRT device, cardiac resynchronization therapy, where you put a normal right ventricular lead and put the second lead on the side of the left ventricle through the coronary sinus to pace both ventricles at the same time. In this particular patient, and I've shown before how right ventricular pacing causes slow conduction and may lead to heart failure. But in this particular patient, we placed a left bundle lead where we insert a lead very deep in the septum, and we're able to capture his normal conduction system. You actually get very fast ventricular depolarization, and the QRS complex looks very narrow. It's usually either normal or looks like a narrow right bundle branch block morphology. And this mode of physiologic pacing has been shown to reduce heart failure and reduce the incidence of pacing-induced cardiomyopathy. In follow-up, his echocardiogram showed normalization of his LV function, and he ended up getting a pacemaker place, a new left bundle pacemaker place. So back to our question, should we remove old leads or simply add new leads? Our evidence suggests that lead abandonment is acceptable, and we don't need to extract all these old leads. Should we offer this patient defibrillator? Technically, regardless of EF, if it's concordant with patient goals of care and clinical status. Why does he have LV dysfunction? Pacing-induced cardiomyopathy should always be considered as a diagnosis for LV dysfunction in somebody who's being paced all the time. And should we offer this patient CRT or alternative pacing modality? One can argue, especially some of these patients are young, to consider physiologic pacing for this patient population. I hope that was useful. Thank you very much.
That was excellent. Thank you very much, Dr. Sadek. Raised very good points, and hopefully we'll have a chance to discuss them. To stay on track, I'm going to introduce our next speaker, Dr. Klein, who's also moderating the session. He's a cardiologist and currently an electrophysiologist at the University of Heart Institute in Ottawa, and he's currently an assistant professor. He's originally from Argentina, so congratulations on the World Cup win, where he finished his training in electrophysiology, joined the Ottawa Heart Institute EP group, and has been seminal in initiating the Neuromuscular Disease Clinic here in Ottawa, and moving care of these patients forward. Thank you, Dr. Klein.
That's good. So I will talk about starting with the case, and then I will review the guidelines that they were released last year. I have no disclosures. So the case is a young patient with myotonic dystrophy type 1. Unfortunately, I wasn't able to get the number of copies that he had. He didn't remember, and it wasn't in the chart. He's on disability, but he has only mild neuromuscular symptoms. He's able to exercise every day and work from home. His father died with a sudden cardiac death at the age of 50. He doesn't remember the details about this. And he had an aunt and a sister who's very sick with myotonic dystrophy too. He had as personal history a traumatic brain injury due to motor vehicle accidents when he was 17, and actually this at this time when he was diagnosed with the disease. So he presented in 2011 with this ECG showing a typical atrial flutter with a rate response of 75 beats per minute, with at that time an incomplete right bundle branch block with a QRS duration of 110 milliseconds. He didn't reach cardiology at this point, and he was followed with the echocardiogram in November 2014. Since he was completely asymptomatic, he wasn't sent to cardiology at that time, and the echocardiogram in 2014 showed a normal ventricular ejection fraction, but it is described already a mild to moderate global hypokinesis. In 2016, he had a follow-up echo showing normal left ventricular size and ejection fraction with no hypokinesis described. And he reached a cardiology attention in 2018 with this ECG, atrial flutter again, with a little faster ventricular response, and the right ventricular bundle branch block with a larger QRS. In this time was 160 milliseconds. That's 50 milliseconds more than the previous ECG in 2011. So that's why with this ECG, he was referred to electrophysiology at Heart Institute at that time. So in order to see him, we ordered a Holter monitor in 2018 that show atrial flutter all the time with the pulses up to 3.8 seconds, which in the context of the sleeping hours and atrial flutter or atrial fibrillation is not very significant, and the patient had no symptoms during the monitor. We ordered an update of the echocardiogram. At that time, it was in February 2018. The ejection fraction dropped to 25 to 30% with severe RV dysfunction too, with global biventricular hypokinesis. So that's why we saw him in the arrhythmia clinic in 2019 in March. With this ECG, pretty much similar to the previous one in 2018, with the right bundle branch and atrial flutter, with a QRS duration of 160 milliseconds. At that time, we discussed different options, such as treating the arrhythmia, and we start anticipating the need of a pacemaker versus ICD at that time. So the patient at that time wanted to see if he was able to reach rhythm control. So we offered him an EP study and an ablation. In May 2019, he was brought to the EP lab. We started the case doing a CTI line ablation. He converted to normal rhythm. We can see this is the 12 lead ECG. These are our ablation signals here, and these last lines are sensing the activity in the atrium, sensing in the coronary sinus. So we can see how the arrhythmia was going faster until during the ablation we were able to stop the arrhythmia and the patient converted to sinus rhythm. So after the ablation, he was in sinus bradycardia at a rate of 40-45 beats per minute. So we completed an EP study that showed the Wenke-Bach time of 140 beats per minute. That means that we paced very fast from the atrium and see how was the AV node able to conduct the signals, and it was able to conduct the signals to the ventricle up to 140 beats per minute, which is a good number. And there was no inducible VT, and surprisingly, the HP interval was in the normal range, was 43. Okay, so we had further discussion with him. This is the ECG after the ablation. As we were mentioning, the QRS was the same with the right bundle and sinus bradycardia. We discussed again the role of pacemaker versus ICD. The patient didn't want to have a device inserted at this point. This was during the pre-COVID time, and after that it was kind of hard to follow him up by phone. He didn't want to come. He only came to having the cardiac MRI. So we were pretty sure that we were expecting not to have a fully recovered of the EF, but surprisingly enough, like the cardiac MRI showed completely normal values. Like the left ventricular ejection fraction was completely normalized. There was no LGE in the MRI. So there is no signs of scar. The right ventricular ejection fraction was still low. So that's how the patient we were following with Holter monitor. He had a Holter monitor in 2021. No flutter anymore. No pulses during the night. With the average heart rate of 56, with reaching some points 100 beats per minute. Patient remained completely asymptomatic. In February this year, we brought him finally to our neuromuscular clinic here at the Heart Institute, and we repeated the echocardiogram, still normal, and we repeated the ECG that shows still sinus bradycardia and a QRS of 165 milliseconds still. So there is still some progressing in the conduction. So at this point, I will check how the case followed after the guidelines. So I will talk now in a few minutes about the HRS expert consensus statement that was released last year. I put this slide, the authors and the many other societies that participate in the development of these guidelines. That I have to say, in the personal level, this was very useful to have. There was no document such as a guideline in this population. So they made a very good job on trying to group this wide range of pathologies in 5 groups. Was very useful to the understanding, especially for the electrophysiologists and the cardiologists that were not usually see this type of patients. The 5 groups are: the first is Duchenne and Becker muscular dystrophy, together with limb-girdle muscular dystrophy type 2, which is the recessive one. There were some changes in the nomenclature in 2017 that they mentioned that limb-girdle type 2 as a recessive type. Second group, myotonic dystrophy type 1, type 2. Third group, Emery-Dreifuss, together with the limb-girdle type 1, which is a dominant version. Facioscapulohumeral dystrophy as a fourth group. And finally, mitochondrial myopathies, including Friedreich ataxia and Kearns-Sayre. So this is part of the table that Dr. Sadek was showing before. I think they did a very good job here summarizing how much cardiomyopathy and how much arrhythmia or conduction disease we can see in any of these pathologies. For example, in the first group, we see more cardiomyopathy rather than conduction abnormality or ventricular arrhythmias. So the ventricular arrhythmias or the conduction abnormality follow the cardiomyopathy. It's very weird to see conduction abnormality in a patient with no cardiomyopathy. In the second group with myotonic dystrophy, it's more the most common affectation. It's a conduction abnormality rather than cardiomyopathy, as Dr. Sadek was mentioning. We can see ventricular arrhythmia or atrial arrhythmias. Second group, we have very rarely cardiomyopathies, but they have a strong risk of having ventricular arrhythmias and conduction abnormality as well. Facioscapulohumeral is very rarely to be affected, but it's a very common neuromuscular disease, so that's why they include it in the guidelines. And finally, mitochondrial neuromuscular disease, they are at high risk of cardiomyopathies and conduction and ventricular arrhythmias. So, do we have to know something about genetics and arrhythmias as arrhythmia specialist? There's some clues that that we can get from genetics testing. For example, in myotonic dystrophy type 1, the number of repeats, it predicts cardiac involvement, whereas in the myotonic dystrophy type 2, that's not the case. In LMNA mutation that we can see in limb-girdle type 1 or Emery-Dreifuss, the truncation mutations on MLMNA are related with sudden cardiac death. Same as Emery-Dreifuss, X-linked, are at higher risk of sudden cardiac death. And in the Friedreich ataxia, for example, greater expansions of JAR triplet repeat, it's related with higher risk of neurological symptoms, as well as ventricular hypertrophy, and patients with will have symptoms very early in life. So it's very important also to mention that this kind of patients should be approached in a multidisciplinary team. A particular example of this is when we bring patients to the EP lab, for example. We always ask for neurology assessment, and sometimes we need pulmonary assessment. Of course, we book any of these patients with anesthesiology support, not only because they are complex patients, also because of the potential life-limiting comorbidities. So go. Yes. Sorry. So
sorry, that was me coughing.
Oh, no problem. So going diving inside each particular category, We'll start with the Duchenne-Becker guideline recommendations. This is something that we are going to repeat in the other neuromuscular dystrophies too. The recommendations about coordinated care that I was mentioning before. In the second part of this table, they talk about guideline directed evaluation. This is not as different from general heart failure guidelines. They talk about periodic retesting for this patient, even without symptoms. They don't mention how often should we do ECGs and echo in this population, but I guess 1 or every 2 years, if results are normal, it's reasonable. They also mention the role of following female carriers as a one type indication. It is shown that even female carriers, they can have later symptoms in life, and they can develop cardiomyopathy. I'm sure Dr. Ghosh will mention about that. And with a little less level of evidence, they mention the role of ICDs in patients with symptoms or cardiac conduction disorders. So we know that the worsening on LV dysfunction correlates with higher grade of arrhythmia. And there's an interesting role. I don't want to go in detail with this because we have a special session about that. But cardiac MRI LCE predicts mortality and cardiovascular events, even with mild LV dysfunction. That means that the cardiac MRI could have a role in predicting ventricular arrhythmias, even in patients with normal echocardiogram. They also mentioned the role of ILR and apps to follow up patients with unexplained syncope or symptoms of arrhythmia. Then in recommendations of pacemaker or CRTs, they are not as different from general guidelines, so I will not go in detail into that. Same as for the ICD use. Recommendations are same as for non-ischemic cardiomyopathy general populations. Secondary prevention, primary prevention, with a special mention that they don't mention for primary prevention the clinical status of the patient, and the special mention that we should say about how important it is to have a lengthy discussion with this patient and be sure that the goals of care of the patient and the frailty and the patient is a good candidate for an ICD, because sometimes there are young patients, but they are still have other comorbidities, and maybe a defibrillator is not in the goals of course. This is one algorithm that they propose, and it's basically if the EF is less than 35%, and there's indications for left bundle for CRT, and the patient is in NYH 2 to 4. The recommendation will be a CRTD at that time. If there is no NYH2 or the patient is not candidate for a CRT, just an ICD, and if a patient have indication for a CRT and prefers not to have an ICD, a CRTP, it's indicated with a stronger class indication. So myotonic dystrophy 1-2. Maybe the most important one, because it's the more common inherited arrhythmia in adults. Inherited neuromuscular disease in adults, it goes globally up to 1 over 8,000, but in Eastern Canada we see as much as often because of this founder effect, up to 1 in 500 cases. CDC repeats that code for dystrophy in protein kinase. It's the mutation that we see. 1/3 of this patient had sudden cardiac death. Although we should mention that not every patient have ventricular fibrillation or ventricular tachycardia in the sudden cardiac death. Some patients died suddenly, just with respiratory problems or even with complete heart block. The CTG amplification, as we mentioned before, is associated with the prevalence of higher life-threatening arrhythmias. It's not the case of the myotonic dystrophy type 2, where the mutation is different. and the symptoms appear later in life, and they are more less prevalent. Going to the guidelines about risk stratification, they mention again periodic retesting and coordinated care between the neurologic and cardiology team. They mentioned something very important. This is a question that we get a lot in an arrhythmia clinic, is the use of mexilatin. We know that there is a conduction disease, and part of the theory that why this patient had the conduction disease is related with a misplacing in sodium channel in the muscular tissue. So use of type 1 antiarrhythmic drugs such as mexilatin can be harmful, but there's well documented trials that it's safe to use it. Although the follow-up data is up to 7 weeks so far, we don't have long-term data about how safe it is to use it. We still recommend to use it because it's very useful for the myotonia in these patients. The recommendation is just to do conduction abnormalities monitoring with serial ECGs, maybe in a week or so, and ideally inpatient monitoring. So the fourth point in the table discuss about the role of an EP study in risk stratification. It's controversial, the role of inducible VT in the EP study, but HB interval more than 70 is shown to be linked with 50% risk of complete heart block in 4 years. So mainly conduction disease surveillance with HB interval, and maybe questionable role of BT stim during the EP study. So in the 5 part of the table, they talk about the EP study. So in terms of bradycardia, same general indications for LV placement, CRT. They are a little more low threshold to treat symptomatic bradycardia, but according to the goals of care of the patient. In the third point, they set as criteria to PACE, which is 3rd degree or advanced 2nd degree, same as the general population, with the only exception that is in any anatomical level, 2nd degree. That means patient with Benkevac, even at night, they will recommend a pacemaker, which is more aggressive than we usually do in general population. And then in the 4th point is maybe the most important point for this table. They set a criteria for pacing that is 1st degree AV block, just with an PR interval of more than 240 milliseconds. They recommend a pacemaker or pacing, and any type of QRS duration more than 120 milliseconds, not necessarily left bundle. They will recommend a permanent pacing with a 2A level of indication. Same as patients with HB interval more than 70 milliseconds noted in the EP study. Concerning atrial arrhythmias, guidelines are for recommendation for anticoagulation, same as traditional algorithm, Chad-Bask and Has-Bled, with the additional comment about the frailty fall risk in this population. The risk of having atrial tachycardia or AFib is up to 12% in this population. And we can see atrial fibrillation or atrial arrhythmias even without significant atrial remodeling, as the case that we presented. The guy had a atrial flutter without even right atrium dilation. About the risk of sudden cardiac death and the role of ICD in this population, the first point that they made is, if we're going to choose an ICD system for the patient, it should be a pacing with a device with pacing capability, because this patient will likely need the pacing in the future. Criteria for primary, secondary prevention extrapolated from the general population, so I will not comment on that. another indication for ICD, patient who had VT documented in the EP study. Special mention about patients, the most common VT that we see in this population is bundle branch re-entry tachycardia. We have a potential treatment with catheters. We can ablate the bundle branch re-entry tachycardia. But even though in patients that was documented and we treated, still the recommendation for an ICD. And this is a 2B recommendation in the last point that Dr. Sadek was mentioning in his patient. If there's a pacemaker indicated, the discussion should be considered for an ICD instead of a pacemaker with 2B level of information. So this is the same algorithm that Dr. Sadek was showing. Basically, if you have criteria for pacing, so the indication is go for an ICD if it goes with the goals of care. If it's not, you go for a pacemaker. If you have symptoms, you go for a pacemaker. If you don't, or if you don't need if you don't want an ICD. If the ECG findings are borderline, mild to moderate conduction disorders, or symptoms are non-diagnosed, but you are suspicious about PT, EP study is recommended, and according to the results of the EP study, we will recommend an ICD or just a pacemaker. So the third category is amyloid-dreyfus and limb-girdle dominant, autosomal dominant type 1. It's inherited in X-linked or autosomal dominant fashion. ED results in mutation in membrane protein hemerin, and in amyloid-dreyfus 2 and limb-girdle, the mutation is in the lamin. The risk, both confer risk for conduction system disease, cardiomyopathy, and sudden cardiac death due to ventricular arrhythmias. But it's noted that the sudden cardiac death risk is higher in amyloid-dreyfus 2 and limb-girdle rather than in amyloid-dreyfus 1. The hallmark finding in amyloid-dreyfus 1, it's atrial and we'll talk about that later. So again, the guidelines about risk stratification and testing start with coordinated care, periodic retesting. It mentioned here that we should screen first-degree relatives because of the penetrance of the inherited problems in this scenario. There's a 2A recommendation for implantable monitors in patients with symptoms of conduction disorder, and there's a 2B recommendation for EP study in patients with risk of sustained arrhythmia, AV block, or sudden cardiac. So according to these guidelines, bradycardia conduction disorders extrapolated for the non neuromuscular disease trial, so there is no difference in CRTD recommendations and pacemaker recommendation. Atrial arrhythmias, we mentioned before, 30% of these patients have atrial standstill noted in the echo. That means that there's no atrial contraction despite a sinus rhythm, and that could be noted as a increased risk of stroke because of the atrial stalling, and even some patients can present with a stroke, young patients with a stroke, and could be later diagnosed with amyloid-dreyfus. So the guidelines about anticoagulation, patients with both disease anticoagulated according to Chatbach score has bled, and in patients with amyloid-dreyfus, as we were mentioning, if with atrial standing, anticoagulation is recommended. Risk of sudden cardiac death and ventricular arrhythmias, same as before. If we have a ICD indicated, we should pick a device with pacing capability. Secondary prevention is a class 1 indication. Patients with PTVF documented. Patients with second degree and third degree AV block with a PR interval more than 230 or spontaneous HP noted in the EP study should be referred for ICD rather than the pacemaker insertion. Guidelines for primary prevention are very similar to general guidelines. EP study, again, controversial, the role of EP VT induction during the EP study, but we still will recommend ICD in those patients with VT induction. Level 2A indication for patients with non-sustained VT and VEF less than 45%. They're making a little more sensitive indication for ICD in these cases. And in patients with ADND with at least one of the following: left bundle, right bundle, or A2 flutter with slow ventricular response, ICD is reasonable with less indication, but it's still indicated. And in patients with sinus node dysfunction, again, ICD it's recommended. So we'll not go. I will not go through the algorithm. That's similar to what we see in the guidelines. Finally, facioscapulohumeral dystrophy is very common, but it's not very significant cardiac involvement. It's very rare. So the guidelines doesn't mention nothing in particular. Mild to moderate ECG abnormalities in about 1/2 of the patient, commonly incomplete right bundle branch block. So the guidelines are very similar to the normal population. So finally, the last group is mitochondrial myopathies, including Friedreich ataxia and Kearns-Sayre syndrome. These are very severe clinical phenotypes. Several include Friedreich ataxia, Kearns-Sayre, chronic external progressive ophthalmoplegia. There's a different type of disease in the same category. About risk stratification, the same as before: coordinated care and periodic retesting for this patient. Recommendations for pacemaker: if the patient have documented symptomatic of any degree bradycardia, they recommend pacemaker. Third, of course, third degree or advanced second degree of any time pacemaker with a strong indication in those two categories. Less strong indication, CRT for reasonable for patients with EF less than 30%, and left bundle and NYH 2 to 4 again. Same as Duchenne Becker muscular dystrophy. And in patients with any degree of AV or fascicular block, permanent pacemaker, it's reasonable. So this is a very low threshold to pace patients. So any degree of AV block, less level of indication, but low threshold to pace. So atrial arrhythmias, again, according to Chad Bask and Hasbled guidelines, atrial fibrillation is seen mainly in patients with progressive external ophthalmoplegias and very common in patients with Friedreich ataxia that they have hypertrophic cardiomyopathy. Finally, role of ICD, same as general guidelines, extrapolated information from non-ischemic cardiomyopathy guidelines, secondary and primary prevention. So the algorithm that they propose is if the EF is less than 35%, very similar to the Duchenne Becker cardiomyopathy algorithm. If there is indication for CRT, NYH 2 to 4, CRTD, if the patient its goals of course are according to defibrillator, if not CRTP. ICD if the patient doesn't have benefit for CRTD, and if the patient have advanced second or third degree pacemaker, or if we suspect that the patient has a conduction disease, abnormally conduction or any type of heart block, including fascicular block, pacemaker. So finally, to wrap up and talk about, I don't want to extend it as much, the patient that we saw agreed to have a pacemaker and an ICD as recommended per guidelines. But I was asking myself if the risk of this patient is as high as the other patient with, for example, left bundle, since he was stable for 5 years with the same right bundle branch block, although there was some progressing in the QRS duration. Holter monitor showed no AV block or pulses. HP was normal, and there was no LG on MRI. I think I will still recommend the device in this case, but seems to be in the low risk category, although it fulfills criteria according to guidelines to recommend the defibrillator. Okay, that's it for me. Hope it wasn't too long. So now, since I'm the moderator, I will present our next speaker, which is also moderator. It's Dr. Ghosh. She's going to talk about guidelines, present the case, and talk about guidelines in myotonic and muscular dystrophies and heart failure. So Dr. Ghosh, it's obtained her medical degree from University of Western Ontario and completed internal medicine resident at University of Toronto and cardiology resident and here at Ottawa Heart Institute. She went to had a fellowship in heart failure and cardiac transplantation in Harvard Medicine School in 2014. She's currently providing community-based cardiovascular care. She works at the Heart Institute with us, interpreting cardiac MRI, and she recently joined our neuromuscular clinic at the Heart Institute following Dr. Lamacie's moving to Auckland. So, Dr. Ghosh, welcome.
Thanks so much for that kind introduction. Can you hear me?
Yes.
Okay, perfect. I'd just like to say thank you for allowing me to participate. This type of conference, Rare Cardiac Disease Conference, rings very personally to me. And just to give a perspective of the lived experience, my late daughter had a very rare neurological condition. It was genetically based. And our lived experience allowed us to kind of promote just the kind of conference we're presenting from a provider standpoint by allowing us to contribute to an endowed lecture on her behalf. So just remember when you're presenting and when you're taking care of these patients that how important you are to the child's lived experience, especially since some of these conditions are quite devastating. So my talk it will involve is about cardiac involvement in neuromuscular disease, in particular focus of cardiomyopathy. I'm going to shorten it a little bit because we're running short on time. And the next, so I'll skip a few slides. These are my disclosures. The objectives are, number one, to provide an illustrative case of neuromuscular disease associated cardiomyopathy, review the salient learning points raised by the case, and to review the current guidelines, the HA 2017 guidelines, and with a focus on diagnosis and management of neuromuscular disease and cardiomyopathy, and to identify some of the gaps in the guidelines for cardiomyopathy and neuromuscular diseases patients. So the patient is DK. He's 60 years old. He presented in 1991 as a young adult with calf hypertrophy, progressive muscle weakness in the hip girdle that resulted in difficulty getting up from the floor or the chair. And muscle biopsy at that time showed decreased dystrophin staining. There wasn't genetic testing at that time. And based on that, his clinical picture, he was diagnosed with Becker's muscular dystrophy. It's unclear when cardiac screening was recommended. Looking back, his rehab doctor referred to cardiac testing back in 2011, and I saw the notes by cardiac rehab to 2018. But at some point, he was actually lost to follow-up by neurology, and it's unknown when he had his last cardiac surveillance testing. He also had hypertension and dyslipidemia, and his family history was significant for no Becker's muscular dystrophy in either of his brothers, and no family history of cardiomyopathy. He used to smoke, but he quit in the 2010s, and he drinks about 2 glasses of wine per week. Those are his medications. In 2019, by then his disease had progressed to the point that he was wheelchair bound at baseline, but he was still independent of his ADLs and most of his IADLs. He could independently transfer from his wheelchair to his bed and to commode, and he had a reasonable quality of life. However, that summer, he started to feel symptoms concerning for PND, orthopnea, and he was also feeling presyncopal. He finally presented in September 2019. to the emergency room, and that presentation was consistent with cardiogenic shock. His lactate was 7.4. He was tachycardic. He was had shock liver, and his echo showed his LVEF was extremely low, 11%, and his RV function was down. He had moderate MR. His ECG showed sinus tachycardia. A left bundle branch block with a QRS duration of 154 milliseconds. He had an angiogram that was normal, and fortunately he was stabilized with inotropes, IV Lasix, and before he was discharged, he was assessed by the advanced heart failure team and deemed, in case he did not get out of this predicament, that he was not a candidate for advanced therapies such as mechanical support devices or heart transplantation because of his overall frailty. Fortunately, he did survive, and he was actually discharged home on some goal-directed medical therapy in 2019, October. This is what his ECG looked like at his presentation. Fast forward to 2020, and he was re-referred, fortunately, to neurology and was sent for genetic testing that confirmed that he had a pathogenic deletion mutation in 45 to 47. In May of 2020, he was assessed for CRTD because his LVEF remained severely reduced despite optimized medical therapy. And because he described no significant residual symptoms, an ICD alone was recommended. Of note, this was during the pandemic, and so there was a delays on cardiac MRI, which was not performed because we didn't want to delay the ICD insertion. In May 2022, he had an inappropriate shock and was found to have a fractured RV lead, which led to a revision of his RV lead. He presented last summer with worsening dyspnea, orthopnea. He checked his own pulse, and poor guy, he was found to be in complete heart block, and he was being paced at 40 beats per minute with his ICD lead. And his pacing parameters were changed to VVIR 60/120. So this case brought up some important points, especially with the dystrophin-related muscular dystrophies. One, that there's significant morbidity from cardiomyopathy, and it's very, very important for there to be ongoing surveillance for cardiac involvement. In this patient's case, he was lost to cardiac surveillance follow-up, and he presented in cardiogenic shock with an LVEF of 11%. Certainly, earlier identification of LV dysfunction may have prevented this near-death presentation. The other important point, I think, is that heart failure in these patients is quite challenging to address. And there are limitations of the NYHA grading system in the neuromuscular disease population. And if we rely on that, that may lead to underdiagnosis and untreated patients. And guidelines that we have available to us with respect to cardiomyopathy are the AHA scientific statement, and as you can see, it's pretty old now. And since that time, there have been new treatments for heart failure in the general population that have been shown to have benefit that aren't included. I'm just going to skip a few slides because they've already been reviewed, and just skip directly to the guidelines. Again, in general, what the guidelines emphasizes the importance of a collaborative team approach. And again, the fact that the heart failure scoring systems for symptoms can be falsely reassuring, and patients can have marked LV systolic dysfunction without symptoms. And also, sometimes it can be difficult to sort out what patients or symptoms are due to, and skeletal muscle weakness can be attributed to heart failure and vice versa. And therefore, evaluation and treatment before overt cardiac symptoms afford patients the best opportunity for impacting morbidity and mortality. So how do you approach these patients? Again, it's important to be proactive, and I'll just skip this one and go directly to the dystrophinopathies. So Duchenne and muscular dystrophy and Becker's muscular dystrophy should have their cardiac evaluation done at the time of diagnosis. So we'll usually fall into the pediatric care scenario. And they should continue to have cardiac evaluations by exam, ECG, and a non-invasive imaging modality if they're asymptomatic every 2 years below the age of 10. And they recommend increasing it to an annual evaluation beyond the at 10 years and beyond. Patients who are asymptomatic but do have evidence of LV dilatation or dysfunction or an arrhythmia should be evaluated at least annually. And once they're symptomatic, of course, at least annually, but likely more frequently, they should be assessed. And as Andreas was alluding, female DMD, BMD carriers should also undergo cardiac evaluation by examination, ECG, and non-invasive imaging starting at the 2nd to 3rd decade of life. This should be followed with evaluations every 3 to 5 years thereafter, as they can be relatively or completely asymptomatic from a skeletal muscle point of standpoint, but develop cardiomyopathy irrespective of their skeletal muscle presentation. And echocardiography should be used routinely in screening and follow-up care of DMD. However, it's reasonable to use advanced tissue imaging modalities such as cardiac MRI because it gives additional information such as late gadolinium enhancement, which Dr. Lamacie will be reviewing. And also in some of these patients, echocardiographic acoustic windows are quite poor because of the body habitus. And so MRI may provide more quality information in terms of accuracy of LV dysfunction. In terms of ECG ambulatory monitoring, I won't go over that because it was covered by Dr. Klein. So I'll just skip over that slide. How about cardiac evaluation in limb-girdle muscular dystrophy? Again, there are 2 subtypes that tend to have more cardiomyopathy involvement, and that's the sarcoglycanopathies and the FKRP mutation patients. And those patients should have at least annual, every 2-year assessment for if they're asymptomatic, and at least annually if they have abnormal cardiac findings. And I'll skip over myotonic dystrophy because it's already been covered in terms of screening. How about medical therapy? So again, we should take probably these guidelines with a grain of salt because they're behind in terms of other treatments such as ARNIs and SGLT2 inhibitors with patients with established LV dysfunction. And therefore, I'll focus on the implementation of ACE inhibitors or ARBs before the onset of reduced EF. And there is reasonable evidence that before the onset of reduced EF in boys with Duchenne muscular dystrophy greater than the age of 10, their use may be considered. And this is based on a study from a group, I think in France, that show that patients received perindopril early on between 2 to 4 milligrams in their disease course before the development of LV dysfunction actually experienced at 10 years a significant mortality benefit. So in the 10-year follow-up, 93% of the perindopril group was alive, and 65% of the control group was alive. How about beta blockers? Again, we should apply the general guidelines to those with LV dysfunction to the neuromuscular disease population, but the AHA guidelines suggest not to introduce them in the absence of other indications if there's no evidence of reduced LVEF. But I know there may be some groups in practice who may be introducing them earlier if there's evidence of higher risk markers like LGE or mild LV dysfunction. How about MRAs? Again, in patients who have preserved LV systolic function with DMD or BMD, there is emerging evidence and that aldosterone antagonists, both spironolactone and eplerenone, may be beneficial to prevent development of cardiomyopathy and improve outcomes in these patients. Glucocorticoids, the use of steroids, and I think Gavin talked about a new agent that may work similarly in these patients, usually doesn't fall in the realm of a cardiologist, but they have been shown to slow the progression of cardiac disease in patients with Duchenne's muscular dystrophy. However, their use should be guided by non-cardiac indications for treatment. How about anticoagulation? I think the evidence is not great, level of evidence C, but it can be considered in patients including aspirin or low-dose anticoagulation in patients with Barth's syndrome who have a non-compaction type of phenotype. And in Barth syndrome, patients who have the non-compaction phenotype have been shown to have a potentially increased risk of systemic arterial thromboembolism. In terms of thrombosis prophylaxis, they should be applied for known established indications in the similar to the non-NMD population. And I skipped over the, of course, the antiarrhythmic ICD, CRT pacemaker, but they're also outlined in the guidelines, but I refer to the HRS ones from last year rather than this guideline, because they're more up to date. And there's, of course, the important issue of end-stage heart failure. And one option for end-stage heart failure are advanced therapies, including mechanical support. And there are complications associated with these devices in these neuromuscular disease patients. Of course, there may be higher perioperative risk, including the risk associated with restrictive lung disease, muscle weakness. They may have quite atypical thoracic anatomy that may impact the sizing and the positioning of these devices. And there may be concurrent need for pulmonary support with or nutritional support with tracheostomy and G-tube feeding, respectively. And of course, when you are adding mechanical support, you're also adding to caregiver burden, which should be considered in these recommendations. How about cardiac transplantation? I think in the past, neuromuscular disease used to be considered a no-go or contraindication. And they have not in the past been candidates for cardiac transplantation, but more recently, and depending on the severity of their condition, there have been many reports and experience with successful heart transplant in patients with less severe forms of muscular dystrophy, limb girdle muscular dystrophy, etc. Because the cardiomyopathy in these conditions can be disproportionately severe relative to the skeletal and respiratory muscle involvement. And of course, home inotropic support can be considered in these patients who are at end stage for quality of life who are not candidates for mechanical support or heart transplantation. And Dr. Lougheed will talk about the importance of transition of care, particularly patients going from the pediatric provider to the adult care provider stage. How about supportive care? Supportive care is crucial. It's recommended regardless of whether they're being assessed for advanced treatment. So overall, their care needs to be multidisciplinary and should involve a detailed discussion regarding end of life, advanced directives, living well, before more advanced therapies are recommended. And when they're at end stage, considerations such as hospice care should be made as well, especially if they have a life expectancy less than 6 months. So in conclusion, there are several neuromuscular disorders that are associated with increased risk of cardiomyopathy that we talked about today. Their care requires a collaborative team approach, and it's important to know that heart failure scoring systems we use in other populations may be falsely reassuring, and marked LV systolic dysfunction can exist without symptoms. Screening and echocardiogram should be performed at the diagnosis of many neuromuscular diseases, and biannual to annual cardiac testing should be performed depending on the type of neuromuscular disease and whether there are baseline abnormalities. The initiation of ACE inhibitors, steroids, and MRAs prior to the onset of LV dysfunction has been shown to be of benefit in boys with Duchenne muscular dystrophy. And the specific guidelines we have right now are the AHA 2017 guidelines, which have not yet been updated regarding the role of newer agents such as ARNIs and SGLT2 inhibitors in the neuromuscular disease population. And then finally, end-stage heart failure is generally supportive, but advanced therapies can be considered on a case-by-case basis. Back to our case. So this poor guy did improve from a symptomatic standpoint. But despite optimization of his goal-directed medical therapy, including Entresto, SGLT2, MRA, and a beta blocker, his LVEF remained significantly reduced. And because of his heart block, he was 100% RV paced. I should have had an RV paced ECG available, but the QRS was quite wide in terms of his RV paced QRS morphology. So when I assessed him, he endorsed symptoms of decreasing stamina and the need to kind of reduce his exercise intensity. And when we checked his NT-proBNP, it was over 1,000. It was 1,400. And so he was re-referred for CRT upgrade. When he spoke to the EPMD, he actually endorsed feeling great. He endorsed no shortness of breath, and he didn't endorse any symptoms of heart failure. So he was deemed not to be a candidate for a CRT upgrade because the guidelines would suggest that it should be reserved for patients with NYHA class 2 to 4 symptoms. That's it for my talk, and I think for the sake of time. And our next speaker likely needs no introduction. He's kind of a pioneer and a trailblazer in the field. It's Dr. Oudit. Am I pronouncing your last name right? I call you Gavin because you were the superstar cardiac fellow, cardiology fellow that I worked with at U of T. But he's currently a professor and a staff cardiologist and a clinical scientist at the Mazenskowski Alberta Heart Institute at the University of Alberta. And his clinical activity places primary emphasis on heart failure and cardiomyopathies. And he currently holds a Canada Research Chair in heart failure. He's the director of the Heart Function Clinic and a fellow of the Canadian Academy of Health Sciences. And he's going to provide us with some advice on a care model for the care of these complicated patients.
All right, so we're talking about muscular dystrophy, and so we've done a lot of work on this, and so it'd be great to be able to share this with your wonderful team, and hopefully, we can work together here. It's funny how life goes around in circles, right? So hopefully we can now work as colleagues, taking care of these very vulnerable patients. So those are my disclosures. Okay, so muscular dystrophy is quite, again, we're talking about rare diseases, but this is quite a diverse group of patients, right? So the patients that struggle the most in terms of their muscular dystrophy and certainly the heart disease are the folks with Duchenne muscular dystrophy, right? Duchenne and the Beckers. So that's shown on the left. The other group is the folks with limb-girdle muscular dystrophy, and there are certain types that do have more of this than others. So limb-girdle 2E and 2I. There is actually a Hutterite mutation here in Manitoba and Saskatchewan that has the 2I mutation that's been reported in the past. So quite a severe cardiomyopathy in those patients. Emery-Dreifuss is rare, but as Andrea showed, it's very pathogenic, and you almost certainly will get into serious heart problems. The myotonic dystrophy is probably the largest group of patients you will see, and their presentation is variable, but certainly the type 1 and the type 2 can get into a lot of conduction problems. And as beautifully illustrated by Syed, that conduction disease is cardiomyopathy, drives the cardiomyopathy, and I'll show you some nice data on that. There are some other types of muscular dystrophy, facioscapulohumeral muscular dystrophy, myofibrillar myopathies, which are very pathogenic, very uncommon. Mitochondrial, we don't see much cardiomyopathy in these folks. We'll talk more about that. And Friedreich's ataxia, this is a bad one. and it leads to hypertrophic cardiomyopathy, and these patients don't do well. This is a very sad group of patients to take care of, and there's no approved therapy for these folks. So the initial drug that came out to protect the mitochondria was withdrawn from the market. So the cardiomyopathy, the pump function and electrical function, right? And so you got to be thinking about both of those very seriously. So I think we'll illustrate some of that as we progress here. So one of the first thing we did was to come up with a multidisciplinary team approach. And it was triggered because of something what Nina talked about, patients that are very vulnerable, patients that are struggling. And so prior to starting up this clinic, when I got here about 15 years ago, these patients were going around all over the city, seeing a cardiologist, respirologist, neurologist, physiatrist. It was terrible, and they have such the struggle with their mobility and so many other aspects of their health. So we said this is ridiculous. Let's come together, form a clinic, and it's a full day clinic, and bring all our patients to us rather than the patients coming to us. So rather than singly, we work together as a team. So that's our clinic now. It has been in existence for about a decade. So patients now, they come to the clinic, we see them all. So, cardiology, respirology, neurology, and physiatry, which is an important part of dealing with patients with muscular dystrophy. We have a social worker, we have nurses, we have a respiratory therapist that are involved. So that's our clinic. And I'll show you some of the data that has come out of this multidisciplinary team approach. I know Calgary, or colleagues in Calgary, have set up something very similar to this now. So that's really taken off there, and hopefully I can work with you guys on this. So that's the clinic, and just focusing on the cardiac portion of it. Obviously, the monitoring, ECG Holters, and the imaging, echo and MRI. And then, of course, an optimization of therapies, including device therapies. And a lot of smart comments made, insightful comments made about device therapies, which we'll come back to. So very important. We've published this a while back now in JAHA, so it was good. And what we showed here was that when you get these patients into a team and people look at them from different angles at the same visit, you improve therapies. You get more patients an ACE inhibitor, beta blocker, MRA. You actually up-titrate their doses of their medications if they're already on that. And you also increase the use of devices, ICD pacemakers. Neurologists by themselves are not going to be comfortable making these calls. So you need your cardiologist in there. And so including CRTP, pacemaker, actually just CRTP, which I'll show you some interesting stuff on that. But Saeed has talked a fair bit about that. So I think it's a very unique group of patients, so that you can do a lot with these folks. And with that strategy, we have been able to improve the ejection fraction of these patients. Let's be realistic. We do improve the ejection fraction 5-10%, but there's still disease. And so, as I've shown you with the Duchenne studies, we got to get to exon skipping. We need to get to precision medicine and start correcting these precise defects. But in meanwhile, this multidisciplinary care with medications and devices are important, and it does improve outcomes, right? But we're not going to stop here, of course. Okay, so in this prospective cohort study, we've been able to, when we follow our patients now for 3 years, but we now have follow-up data from 6 years, we actually dropped their outpatient visits by a significant margin. We have decreased the duration of hospitalizations when they do come into hospital, and we've been able to optimize the medical therapies. So, we can, because this is a prospective cohort study, we can't talk about improving mortality because it's on RCT. But we are reducing outpatient visits. We are reducing duration of hospitalization, and of course, up-titrating their medical therapies. We actually included in the study a negative cohort of non-muscular dystrophy patients with myopathies, but with no heart disease, and showed that this was very specific for patients with heart disease. Biomarkers are so important, and we're fortunate to be able to collect biomarkers in these patients. I know our colleagues are talking about this after, and so we are shown here very subtle but important elevation in BNP and high sensitive troponin I. And they're clearly elevated in patients of cardiomyopathy. This is not, look at the BNP increase there, right? Very subtle, not classic for your dilated cardiomyopathy that has BNPs in the thousands or hundreds, right? So very subtle increase, but it's there. And I think the high sensitive troponin I is equally important, if not more important. So we have shown there's increased detection here with the BNP high sensitive troponin I. When you use both of these biomarkers together, the area of the curve gets up to about 70% or greater. So they are good markers of cardiomyopathy. Fascinating, the global CK levels, so the overall CK levels, and high sensitive troponin T were of minimal clinical utility. So they were elevated, but not diagnostic. So I'm going to propose to you young, smart folks to come up with an explanation for that. Not for the CK. CK, of course, you know, most of that comes from the skeletal muscle. Doesn't mean much here in terms of the heart disease. But why would high sensitive troponin T not be so useful? So here's the data in terms of the prognostic utility of BNP and troponin I. So the BNP, we use that cutoff. So there's a dichotomic approach cutoff here, and they clearly predict outcomes. So I have now officially started doing BNP. We have switched to NT-proBNP and high sensitive troponin I. I think most of our academic labs have it. So I've now switched to measuring these now routinely in our patients. So a very important change in how we're managing our folks. The other biomarkers, I showed a bit of this, but tenastin C levels in the dystrophinopathies are very elevated, and they correlate with myocardial fibrosis in the Duchenne muscular dystrophy. So very unique biomarkers for fibrosis in Duchenne muscular dystrophy that's now been targeted in animal models, but also now moving into clinical trials as a marker of as a potential to reduce the burden of myocardial fibrosis in the Duchenne muscular dystrophy folks. So again, as you set up your program, do collect biomarkers, do get your registry going and your consent, and you know, the biomarkers are just so important to understand these patients better. So that's the biomarker piece. With the collection we have, we will be doing proteomics and metabolomics, and we will be linking this with, of course, analytics and outcomes. So I think we have a lot of exciting work to do here in the future, and with our colleagues here as part of a team. So one of the interesting, you know, and it's really, you know, it's amazing physiology is that, you know, their creatinine is useless as a measure of GFR. You guys all know that, of course, right, as astute clinicians. So the creatinines are super low, so you just can't use them as renal function measures. So, you know, cystatin C is something we're going to be doing next, and it's probably a better marker of renal function in these patients. But this is where your clinical skills, right, going back to our early days, is so important. And so I've increased ACE inhibitor, I've increased MRA, all of that without knowing the true renal function in these patients, right? So you jump in there, you get going with it. You do have to follow their lights. You know, it's not always easy because of the mobility issues and so on, but we have not had significant hyperkalemia despite not having a true measure of renal function. Creatinine is not useful in these patients at all. So, okay, the 12-lead ECG, going back to basic stuff, so very critical. We have a dedicated ECG machine in the clinic, and we do have ECGs on our patients. And I can tell you, looking at the ECGs by themselves, I've now almost stopped doing Holter monitors. I know so much by looking at the ECG about these patients that the Holter monitors are not that critical. In a very small fraction of patients, we have to do it, but the ECG has been very revealing. So traditional ECG. So things like QRS fragmentation in the left bundle branch block. So very important finding. Of course, the widening of the QRS left bundle, fragmentation of that QRS. These are all markers of increased risk. We have published and some of this. So I think beyond just looking at the QRS duration and the PR interval, there's more to be gathered from the ECG. This is a great case here for AI and machine learning, and to be able to scan these ECGs and to come up with better predictive patterns in these patients. But there is more high-risk features in ECG than what we see traditionally. So we see patients with the left bundle branch block do worse than patients without left bundle. So their ejection fractions are lowered as shown in this study, and QRS fragmentation is linked to cardiomyopathy. So very interesting ECG findings. And so this gets back to what Sadek was saying about how much of that cardiomyopathy is bundle branch block driven. And I think a lot of it in the myotonic dystrophy is bundle branch block driven. We've also shown the traditional thinking that we have learned in med school and residency, the tall R wave in V1, V2, very sensitive. Sorry, not very sensitive, very specific for dystrophinopathies, almost 90 to 95%. Not very sensitive. The sensitivity was about 50, 60%. So flip a coin. But if you see it, it's a good marker that this patient has dystrophinopathies. One of the fascinating part of this study we did was to look at LVH, and our gold standard was cardiac MRI in those patients. Terrible at LVH. All the ECGs look like they have LVH, right? Because they have thin chest, atrophy of the skeletal muscle. They all have LVH based on the machine reading this, right? But we know these patients don't really have LVH. It's very minimal. And so that is mostly, almost exclusively a false positive finding. So anyway, so quite fascinating. We're able to publish on these ECG findings. Left bundle branch block. Let's get into serious EP stuff. So very important. We did a nice study here with a great colleague of ours, Suri Sivakumarian, very experienced at putting in CRT devices. So a small cohort that we have looked at patients with left bundle and the use of CRT. And so what we did here was we tested the hypothesis that so much of this is driven by the synchrony and the pacing and the conduction disease. So we actually just put in CRTP, and just with the CRTP, two things. One, the rejection fraction improves and we shorten the QRS duration, but equally, and it's unethical not to do this, we are able to up-titrate the therapies, including using a beta blocker. And a beta blocker is so key here because of the risk of VT. So you want to put a beta blocker in, but you would not do that unless you have a CRT pacemaker, because of that conduction disease, right? So this is where the CRTP pacing here is so phenomenal, allowed us to increase therapies, allow us to establish some degree of synchrony. And I totally agree with Sadek was saying, left bundle branch pacing is the way to go. And that's what we're going to be doing now from now on. So far, we've been doing mostly LV epicardial lead. You do need respirology, by the way, on board, and anesthesia. These patients are sick, they have a lot of respiratory conditions, so you do need to have this set up either in the EP lab or sometimes even in the OR to be able to do this. So they are high-risk patients, so you need to recognize the respiratory risk, don't minimize it, and get anesthesia involved because you can get into trouble. So it took us a while to gain a lot of experience in that. Andres talked about VT. Big problems in type 1 myotonic dystrophy. We did not recognize this up front. We did not. And so we actually had a flurry of patients showed up to the emerge with VT, some that have arrested. And so we now recognize, and this is others have shown this, that VT is a real problem in type 1 myotonic dystrophy. So poor patients, they have all sorts of muscle problems, but they have serious heart problems, conduction disease, but also VT. And so these are patients that get the CRT-D or they get upgraded to a CRT-D if they've had a CRT-P. So very interesting group of patients to manage, very serious arrhythmias, and this kind of stuff that keeps you up at night a bit, right? So anyways, a sick group of patients, and we have to be on top of this. So you need to get your EP colleagues on board, and it's great that you guys have done that. So they're such a big part of the cardiology team. Finally, I just want to finish up with some MRI stuff and how you can use the imaging. So both echo and MRI in our patients with muscular dystrophy. So this is a study we looked at quite a large cohort here, as you can see the numbers with echo. And so the echo is important, don't throw the baby with the bathwater. And so the MRI, of course, is the gold standard. We know that for any tissue characterization, RV, LV, ejection fraction, it's MRI. But many of these patients can't get into an MRI. They have accessibility issues beyond that. And so here we looked at echo. And the echo picks up the cardiomyopathy, and that's the important message. You have to train the echo lab. So we also train the echo lab. These are patients who show up in wheelchair, who have mobility issues. You have to lift them off their chair onto the bed, and you may need 2 people to do that, right? Patients are very comfortable with that, but the echo lab folks need to know that, all right? So it took us a few years. We did get some pushback, but that education, and you got to reach out to people. You got to connect with them at a deep level, right? These are folks, young folks, typically, that are struggling, right? And why shouldn't we help them out? So that's a big motivation of what we do. And here the echo does correlate. On the right, you can see it correlates very nicely with the MRI findings. So very important study. And you can see the drop in ejection fraction that you see predominantly with the dystrophinopathies. You do see it in the type 1 myotonic dystrophy, in the presence of left bundle. You see it in certain types of the limb-girdle muscular dystrophies, okay? It's also predictive of risk, so a drop of ejection fraction. You can see that when we stratify these patients based on their risk, they are predictive of adverse MACE events based on a cutoff, a dichotomy study here. We just don't have the numbers to do multiple cutoffs, but these are decent cutoffs that are very practical, that does show that they have important prognostic features. And our follow-up data here in Alberta is solid, right? We capture everything in our electronic medical records, so we now have 5-6 years of follow-up data. And so this is quite thorough and complete. So clearly, any drop in ejection fraction is associated with increased adverse outcomes. We were also able to describe uptitrate medical therapy, device therapies, and very importantly, patients that improve, their risk almost dropped to the level of patients without cardiomyopathy, as shown there in the bottom right. Those patients that continues to have reduced ejection fraction for whatever reason do terrible, okay? So the reduced LV ejection fraction hazard ratio was 7.2, okay? So again, a follow-up here of close to 5 years. So very good outcome data. If your ejection fraction does not improve, you're in trouble. And so that has to be taken very seriously. Okay, I've shown you the echo to guide CRT implantation, doing the follow-up study, clearly showing an improvement in ejection fraction. It's not large, it's about 8 to 10%, and there is a small reduction in QRS duration, so we need to do better. Left bundle branch pacing, I will go with that. I think it's better at reducing QRS duration, probably will lead to better improvement in ejection fraction. So again, the technology continues to evolve. That's cardiology, right? And we can now apply this to our patients in various ways. So pretty exciting finding here in this type 1 myotonic dystrophy. I'll finish up with our massive MRI study. So this is a study we did with Calgary. 40 healthy controls, 22 dystrophinopathies, 27 limb-girdle muscular dystrophy, and 31 type 1 myotonic dystrophy. So you can see the drop in ejection fraction there in the dystrophinopathies compared to the other types of cohort. That symbol and the type 1 myotonic dystrophy is to declare that in patient with left bundle, you do get a drop in ejection fraction. What we don't get is hypertrophy. So very minimal or no hypertrophy. One of the fascinating things we saw here was the type 1 myotonic dystrophy has reduced LV mass. So reduced LV mass. So this is very interesting why that's happening. So we'll come back to that in the discussion. The Duchenne muscular dystrophy are the ones with the myocardial fibrosis. We don't see fibrosis in the other types of muscular dystrophy. In a few of the limb girdle, we see it. But in the type 1 myotonic, it's not a fibrotic phenotype. And that conduction disease is there because of that genetic defect in the conduction system. It's not a fibrosis. So very different from the Duchenne muscular dystrophy, okay? So that's the important data to know. We also did all these fancy strain analysis. The echo folks do this, but we're actually able to do 3D strain, radial, circumferential, longitudinal strain, and we're able to look at minimal relaxation and contraction strains and looked at their ability to predict events. And so this is our outcome data. We have shown that these patients do have a high burden of events. including arrhythmias, device implantation, hospitalization, new onset heart failure, and unfortunately, cardiac-related mortality. So here is the outcome data now from looking at, let me just see here, the median follow-up was 5.2 years. So this is Edmonton and Calgary cohort. Reduced ejection fraction is predictive, reduced strain is predictive, but importantly, the minimal principal strain, that's on a 3D strain, is the most important predictive value. So shows that these folks have a problem with impaired relaxation. And you know, that goes to the molecular defect in these patients, right? So when they can't relax properly, you get into trouble, and it's the most, the numbers are shown here. The adjusted hazard ratio is 5.5 for the minimal principal strain reduction. All of these things are increased, but the principal strain is the most predictive in these patients. So very interesting finding. Of course, sharing this with you in confidence that as it is under review. But very interesting cohort that we were able to study. Finally, mitochondrial conditions. So, you know, you see this, MELAS, yeah, of course, classic cardiomyopathy, very severe. These patients do get very sick early on in life. That's a no-brainer. For the folks with neurological manifestations, we don't see cardiomyopathy. It's very, very low, including folks with CPEO, NARP, and MRF and so on. They tend to have a low burden of heart disease when they present predominantly with neurological problems. So we have published on this, and so I think that's important data to know. We're able to triage our patients a bit better with knowing this type of stuff. So to summarize, you know, we're looking at adverse remodeling from fibrosis, reduced ejection fraction, conduction disease. We're able to, with working as a team, improve medical therapies, device therapies, unique application of device therapies, and with that, we're able to improve the outcomes of these patients. Some, you know, recognizing the unique features, dystrophinopathies having a marked reduction in function, largely in coordination with fibrosis. Type 1 myotonic dystrophy having smaller hearts. I've never really seen that outside of cachexia or cancer therapy. So it's a fascinating finding. They actually have smaller than normal hearts with reduction in systolic function driven by left bundle branch block. So I think it's important as a team. You work as a team, as a multidisciplinary. But even when you come down to the cardiac issues, you need a team approach. You need an echo lab to be on board. You need a cardiac MRI folks that can handle these patients, that can move them from the lift into the MRI system. You need an EP team that's very, very insightful and is really to take care of these folks. You need anesthesia on board and sometimes respirology to provide respiratory support during the implantation of devices. So that's also part of the team. So I'll just stop there and thank you.
Thank you so much, Gavin. That was an excellent talk and so much to learn from your experience. For the sake of time, we'll move on to Dr. Lougheed's presentation. We're lucky to have a pediatric cardiologist here to speak about her experience and help us figure out how to best transition the patients to adult care. She is the chief of pediatric cardiology and fetal cardiology at the Children's Hospital of Eastern Ontario here in Ottawa. She is an associate professor with the Department of Pediatrics at the University of Ottawa, and she has a large clinical practice, including general pediatric cardiology with specialty clinics in fetal cardiology, neuromuscular disorders, and heart failure. Her research interests include fetal cardiac outcomes, physical activity in congenital heart disease, and the genetic basis of congenital heart disease. Thank you very much, Dr. Lougheed.
Perfect. I'll just confirm that you can hear me and you're seeing my slides.
Yes.
Perfect. Good. Good. So thank you very much for inviting me to speak at a more of an adult conference. And so I will be talking about our approach to transition to adult care from a cardiology perspective. One disclosure to place. And over the course of the next 20 to 30 minutes, I want to highlight some of the differences in the cardiac spectrum of disease that we see in the pediatric world, because they are different from what you guys experience in the adult neuromuscular world. Talk about some general themes of transition to adult care, recognizing that you can have an entire conference for multiple days on how to transition patients. And then talk a little bit about what we are sort of doing currently and ways that we could improve in terms of our cardiology transition planning. So I'm not going to go through all of the details of the neuromuscular disorders because we've had a nice overview of that. The spectrum of disease that we tend to see in the pediatric world, we definitely see the dystrophinopathies, especially the Duchenne patients, because they are typically diagnosed quite young. We see Becker muscular dystrophy patients to a lesser extent, and a lot of myotonic dystrophy patients. We then have a grab bag of a lot of congenital muscular dystrophies and myopathies that you've spoken about, the mitochondrial diseases, metabolic diseases. There's sort of a grab bag of other disorders, a little bit of a different flavor of those disorders from what you will be experiencing in the adult world, because some of these disorders are actually lethal in the pediatric period and don't make it to your clinics. I will add that the details of these myopathies and muscular dystrophies are becoming more and more with advanced genetic testing. We're getting more and more information than ever about some of our children that were kind of lumped into a big category of congenital muscular dystrophy. They now, a lot of them have named disorders or identified genetic abnormalities, which is going to prove helpful in the future in terms of how to best follow these patients. If we look at Duchenne muscular dystrophy, again, I'm not going to go through all the details of it, but it is the most common muscular dystrophy that we see in the pediatric world. And there is quite a variable age of presentation, though I will say that we are seeing more prenatal diagnoses or very young diagnoses, some of it because of family history, some of it because of the level of genetic testing that is now being offered pre and postnatally. So we are seeing younger and younger boys. It's not uncommon for me to get referrals when these are 1 or 2 year old children, whereas previously it would be more when they started having walking problems, which is more in sort of around age 5 to 6 years of age. Most of these children are non-ambulatory in about mid-childhood, in their around age 12. And the life expectancy that we're, at present is up to into their 30s, although that may change with some new developments in the area. If we look at the cardiac disease that we see in our Duchenne muscular dystrophy patients, as previously mentioned, dilated cardiomyopathy is by far the predominant presentation of cardiac disease. That being said, it's generally a disease, at least clinically significant, when these kids are in their mid to later teens, which is transition age, which adds to some of our difficulty then with making sure our transition processes work well for these patients. Now, some of this comes down to how we diagnose cardiomyopathy. If we diagnose it by EF on echo, that's going to be very different than if we diagnose it on MRI by seeing LGE, because we do know that there are changes on the MRI long before we see EF changes, and so it's part of how the prevalence of the dilated cardiomyopathy depends on how we're actually defining it. But in the pediatric world, we almost always are seeing abnormal ECG findings consistent with the tall R waves in the right precordial leads, the deep and narrow Q waves in the infralateral leads. Less likely to be seeing the bundle branch block patterns or profound conduction system abnormalities. Much less common to be seeing arrhythmias. I can count on one hand the number of atrial arrhythmias or SVT or VT patients that I have seen over 20 plus years of practice with Duchenne muscular dystrophy. So these are later onset and often mostly associated with the dilated cardiomyopathy developing, but the atrial arrhythmias seem to be a separate entity. There are disease-modifying therapies that we expect to become more commonplace, and perhaps this is our hope, where we hope to see something that actually changes the long-term outcome in Duchenne muscular dystrophy, because most of what we have is treatment, not prevention, not really disease-modifying therapy. So we've touched on the issue of steroids. We don't really fully understand the entire mechanism for steroids, but certainly they are in the mainstay of from the neurologists in terms of treating Duchenne muscular dystrophy. And, they definitely postpone the non-ambulatory phase, and children who are steroid naive tend to have far worse and earlier cardiomyopathy than children who are started on steroid therapy early in their course. There are some experimental studies at present looking at myostatin inhibitors and gene therapy that hopefully will hold some promise for these families for something that actually modifies their disease. We've already touched on in the guidelines the cardiac therapies, and the key one that we discuss a lot in pediatrics is the parenteral trial from France, where there was small numbers, but potentially an improvement in EFs and a lower mortality in the children treated long-term with parenteral on a preventative basis. And this is what has really pushed the current guidelines to suggest that early treatment with ACE inhibitors as a preventative strategy is maybe indicated in patients over 10 years of age. But the data is small, and it's probably not going to get, we're probably not going to get a lot more data in this regard, but it's something that we do discuss with all of our families. Some families decide they would like to go on an ACE inhibitor on a preventative basis. Other families really are not interested in that until there's actually changes either on their MRI or on their echo in the EF or in LV size. ACE versus ARB, we have some limitations just in terms of what drugs are approved in pediatrics, and certainly once the ejection fraction is changing, once we're transitioning to more of a true heart failure treatment pathway, there are some differences in children versus adults in terms of what meds are approved. Most meds aren't actually studied, even if they're approved, but certainly ACE versus ARB, there's probably not a big difference in terms of preserving or improving EFs. Eplerenone, not a lot of experience in the pediatric world, but certainly once we're into heart failure management, eplerenone or spironolactone come into the therapy algorithm. Other sort of novel, the ARNIs and SGLT2, very limited experience. Actually, probably I don't think there's any experience with the SGLT2 family of medications, and limited information with the ARNI. But this will change in the future. But we don't have quite as many meds in our armamentarium compared to what you would have in the adult world. And a lot of what we're talking about in the peds world is more this prophylaxis and this sort of dilemma we're in terms of, is there actually enough evidence to justify putting a child on an ACE inhibitor, parenteral being the most common one used, just because that's the ACE that was used in the studies. We survey these patients annually with clinic visits, echocardiograms, and ECGs. And then every 2 to 3 years, we do try to do CMRIs with LGE and Holter monitors. MRIs are challenging in young patients. Under age 10, it's very challenging for a lot of kids to lie still and cooperate and not be scared and not have to have a general anesthetic. And then as they get bigger, they have scoliosis. They've got bony pain. They're often quite large patients, and so it's not as easy as to do regular surveillance MRIs as one would think, but we are really pushing to have that first screening surveillance MRI done around 10 years of age if we can get cooperation of the child and family. And most of the time I am discussing and recommending starting an ACE inhibitor after 10 to 12 years of age, depending on the child's size, and then we add in spironolactone or eplerenone and a beta blocker, depending on the degree of cardiac dysfunction. But the ACE would be more on a preventative strategy. And we do see some Becker MD patients, but they're much less common, both in terms of it is a less common disorder, and a lot of these patients do present a little bit later into life. They tend to be ambulatory well into adulthood, but they may present with cardiac findings. I have a family of 2 boys. The older brother presented with what we thought was a dilated cardiomyopathy, end-stage cardiomyopathy. We thought it was myocarditis. He ended up having a transplant. His transplanted heart showed evidence that ultimately gave him a diagnosis of Becker muscular dystrophy. We then test his younger brother, who also has it. So sometimes these patients present in unusual ways. We've already talked about the carrier status, but whenever we see the child, we also see the mom, and it's very important to have that discussion with the mom in terms of getting carrier status clarified, and then reaching out to her primary care provider to ensure that she is referred for the appropriate adult care. I'm not going to talk about the other muscular dystrophies and myopathies because you have touched on this. Most of these don't present in childhood. Some of them do. Most of the cardiac complications also don't present in childhood. But if we are aware of these diagnoses, we do variable degrees of surveillance depending on the specific diagnosis. Again, myotonic dystrophy, this is the other neuromuscular disease that we see larger numbers of. We often see more of we do see the younger onset type 1s. We only see type 1s. And we do have this range from the congenital type 1s who are typically ventilator dependent, very unwell babies that may die in the neonatal period, up to the more sort of traditional type 1 presenting with the myotonia, some muscle wasting and weakness, muscle cramps, and quite prominent developmental delay and behavioral differences. And oftentimes we diagnose myotonic dystrophy, and then subsequent to that, we get a family diagnosis because the mom has never actually been diagnosed because of the intergenerational instability of the CTG repeat in this disease. With most of the cases, between generations, the repeat expanding, we tend to see worse disease that then we can backtrack up and say, oh, actually, mom and grandpa who might have quite mild disease. In retrospect, you're like, yeah, no, these guys all have it. And then it's very obvious. But because it amplifies generation after generation, it's a very interesting disease in that perspective. So we often will have this cascade then of diagnoses that develop in these kids. And then the cardiac issues are much less common in the pediatric ages. We get weird ECGs in these kids with varying degrees of intraventricular conduction delays, but actually having atrial ventricular arrhythmias, sudden death, dilated cardiomyopathy is actually quite rare in this population. We do annual to biannual surveillance on these patients with ECGs, Holters, and echoes periodically. To be honest, we don't really have much to intervene upon. But some of the annual or regular surveillance also is building up this pattern of care in these families so that they're used to having this. They know they have heart issues to think about. And that's really important when in transition because they're already accustomed to knowing they have to come to a cardiology clinic for their care and for the rest of their life. So if we talk about transition to care, to adult care, the next step in a youth's life after we're sort of wrapping up their care as a child is that we have to move them into adult care. And the age of this varies depending on the location, but in our province, it's 18 and above. And it's important to recognize that there's transitions in multiple areas so that we're transitioning medical care, but this is also a time where children are transitioning to their school setting potentially. They might be starting a job. They might be moving to a new residence. And then all of the child things like child tax benefits and, OHIP plus and all of these things that you get as a child now turn into adult issues like insurance, pensions, tax benefits, things that we don't really think about a lot in pediatrics, but are really important once you're in the adult world. The other thing with the transition is that, more adult care tends to be more compartmentalized. You see your respirologist, you see your cardiologist, you see your, psychologist very separately. Whereas in pediatric care, we tend to bring it all together and have more holistic care. Now, I was very encouraged to hear about Edmonton's program because I think that's really where we should be heading to really be bringing all of the care together. And that may help with the high rate of problems that are seen within the transitional period. If we look at something like like, diabetes mellitus. There's a lot of information out there saying that, 30 to 40% of diabetic kids, as they transition into adult care, are lost to follow-up, have experience major complications. There are problems with this transitional period, and it's not just giving them an appointment card and saying, hey, here's your next doctor, go see them. When we look at our patient and family experiences more in the adult congenital heart disease world, because that's where we have more experience with transitioning, the patient and family experiences tend to be more negative than positive. And some of the negative things we hear is that, the patients get lost in transition. There's no appointments given to them, or the referral gets lost. It goes into some vanishing pile somewhere, or vanishing EMR, and they never hear from anybody. It's hard. It's a hard transition for a lot of patients going from CHEO, or a children's hospital with bright colors and everybody smiling and, nice little gift shops, to the adult hospital where it tends to be more of a cold and sterile environment. It's different. They need to be prepared for that. Some patients will give us say they go to the waiting room and they're surrounded by old people and they feel very uncomfortable and everyone's staring at them, wondering why they're there, because they're young and most of the people that are sitting in the waiting room are 60 plus. There's a concern that nobody understands their diagnosis, and that comes from when we refer a patient to an inappropriate adult specialist. So just like not every pediatric cardiologist has the same experience with certain diseases in the adult world, you've got catheter people, EP people, heart failure people, general cardiologists, and you have to pick the right person or know who that right person is so that they actually will understand the diagnosis of the patient when they arrive. There's a comment that medical records go missing. Hopefully that will improve with EMRs, that nobody talks to any other specialty, that they're really looked in isolation, and the cardiologist doesn't speak to the respirologist, or even within cardiology, the heart failure person doesn't speak to the EP person, adding to this sort of compartmentalized care. And then one thing that is we hear a lot of is that the parents are not welcomed or allowed, even with COVID, not even allowed into the appointment. And that can be a very negative experience, because they've gone from an environment where parents are very actively involved in care to not being involved. And we have to work on our end to improve that. But there's also work on the adult end to recognize that this transition experience is actually very important. So there are resources. This is one example from the PCMCH Ontario experience. So it's a resource guide for how to transition. So the guiding principles are that you start early, you gradually have the child assume more of their care, and then you try to transition them with as little loss of information as possible, because that's a big problem, is you lose medical information whenever you move from one doctor to another. Bits and pieces, the nuances sometimes get lost. Now, if we look at the neuromuscular population, what are the challenges specific to this population? Well, the range of disease and the needs of the patients are quite variable, depending on what the actual disorder is. There's high levels of parental dependence, especially in the children who are physically limited. Parents are driving them around, bringing them to every appointment. They are their support people for the most part, and so there's a lot of dependence. Parents and patients tend to have a high level of expertise in their disease. This varies, but we often have parents who are very much the disease expert. They have been in contact with every center that specializes in their area of neuromuscular disease. They may have traveled to Cincinnati to have pediatric cardiology, neuromuscular care with one of the world experts. They may be involved in clinical trials. There's a big support group, and parents can be very, very, very involved in this and have a high level of expertise. And then if the physician sort of tries to put them down, that can be a very negative experience. The physical disability and dependency is a real challenge that was already sort of mentioned. Developmental disability as well. So we know with DMDs and the myotonic patients, the vast majority of these children have developmental disabilities. They are not functioning at the same intellectual level as many adults. And so that has to be recognized, because their ability to comprehend the discussions, make decisions, may be limited. We know that neuromuscular patients tend to have lower socioeconomic status. Some of that's because one of the caregivers has had to quit their job. it may be related to a family history of something in the myotonic dystrophy families. For example, if a parent has a learning disability because they were never diagnosed with their myotonic dystrophy, they may end up with a low-paying job. So lower socioeconomic status is very, very common, and that's a challenge. We also look at parental disability. So if parents have myotonic dystrophy, for example, that limits perhaps their comprehension of their child's disease, their ability to bring their now young adult for care. And as we also mentioned, these patients are used to multidisciplinary care where they come to the neuromuscular clinic and it's kind of one-stop shopping, and that can be a big challenge to mimic that type of a clinic in the adult world. So how do we try to do it in our pediatric center? I see it as sort of being three stages or three components of this. The first thing I think is the physician, you have to have these children or youth medically prepared. And so you need to be aware of what the guidelines are for neuromuscular disorders, what the baseline testing and surveillance should be, so that is all done before their last appointment. Because what you don't want is to see the 18-year-old say, okay, now I'm going to order all these tests, but you're too old for me, and so those tests are going to be followed up by another doctor. That doesn't work. That's practicing poorly. We want to make sure that our medications are at adult dose levels. They've got lots of refills to hold them over until they're seen by their next care provider. And we also want to have an interim plan in place. We do not leave our patients hanging. And so they are aware that if something changes, they're sort of discharged from our clinic, they faint tomorrow, that they actually call us, and we're still their care provider until their new provider has taken over their care. So they're not left hanging. And that hopefully will decrease some of these patients who, are sitting there waiting for 2-3 years. Nobody calls them with an appointment. They feel like they have nobody to turn to. Liaising with the adult provider is very important. And so it's more than just generic heart failure management, more than just generic EP management, as you guys have outlined. And so we need to make sure that we have identified who the experts are in the neuromuscular cardiac diseases in our community or in communities that we refer to ahead of time, so we actually can liaise with these people. And I look forward to meeting with sort of the new team at the Heart Institute to really make sure that we are sending patients to the appropriate specialists, and also to understand what information you guys need to be able to then manage these patients the best. Do you need MRIs, for example, on DVDs, or can you access them, for example, through our EMR? And the patient needs to know who they're going to be referred to, when and where that person is located. Now, preparation of the youth and family. If we look at the PCMCH guidelines, this is a process. This doesn't happen on the last visit where you say, okay, here we go, all done. You're going off to the adult world. This is the process that starts, and I'm not going to go through all the levels of this algorithm. This is a general algorithm for many issues. But what we try to do is make sure that they have knowledge of their cardiac disease, what to expect, what to watch for, what follow-up they need and when. Plan for the interim health issues and when to go to the ER, when to see their PCP. We try to make sure that they understand that they need to advocate more for themselves. Something that's important to understand in pediatrics, if a child doesn't come to their medical appointment, we can't be like adult clinics and say, you know what, they didn't come, that they obviously don't want the care. Because the child generally isn't the one deciding if they make it to their appointment. It's the person who's driving them or bringing them to the appointment. And so we chase people down. So if you don't come to your appointment to see me, we're going to find you. We're going to do our best to find you and make sure you come to your follow-up appointment. In the adult world, it's a very different experience. And so we've had patients that they don't show to their first appointment with a specialist, and that's it. It's one strike and you're out. And so we need to make sure that they understand. They need to advocate for themselves. They need to take responsibility as well for making sure that those appointments happen. Making sure that we have good access to either paper documents or hopefully EMR moving forward, so that our adult caregivers have access to all of the medical records, and also having our patients and families now with things like MyChart having access to these things as well. So again, they can really take a little bit more ownership of their healthcare, and we start encouraging this when they're 12, 13 years old. And then we will often, not so much in cardiology, but I know in the neuromuscular clinic, social work starts a process when these children are sort of 15, 16 years old to start to get the paperwork in place for ODSB, drug benefits, any accommodations that might be needed for school, et cetera. Considerations, I think, for future or things we can really improve on would be, is there a role for joint transition type of appointments where either virtually or in person, the team actually comes together, the receiving physician and the giving physician and the patient come together to make sure that this is fully, it's a more streamlined process. Having a fully shared EMR where I can look at your images, you can look at mine, you can read all of my notes, that would be ideal. And then I think moving forward, having joint neuromuscular cardiology rounds where we can actually see what happens to our patients. I know certainly in the adult congenital heart disease clinic, it's very useful for us to see what our 30-year-olds and 40-year-olds look like, because that's actually very relevant to our discussions with the child when they're younger in terms of what life is going to look like for them down the road. So I hope I've given you a little bit of an overview of sort of what we're seeing in the neuromuscular clinic, some of the general themes of transition to adult care, how we're currently doing our transition planning, and how we potentially can make things a little bit better moving forward in this population to make sure that they really truly have the best care. Thank you very much.
That was excellent. Thank you very much. I really enjoyed.
Thank you.
We're going to have time, hopefully, at the end of the afternoon to questions. So I will present our last presenter of the afternoon, Dr. Lamacie. Dr. Lamacie is an imaging and heart failure cardiologist with experience with CT and MRI reading. She developed and co-lead the cardiac neuromuscular program at the Heart Institute until last year that she moved to Auckland, New Zealand. So thank you very much, Mariana, for being here and presenting. I think we have to thank you not only for being here, also for being here that early for you, and also for making our presentation international level.
Well, thanks for inviting me to talk in this meeting today. I have a very special feeling for this program, and I'm very happy that this could be carried on by very well by Nina and yourself. And as Dr. Lougheed mentioned, when we created that, the patients and the families were very happy, and so they have a reference and they had a direction to go. So I'm very happy that we can care. You guys are able to care. Dr. Gavin's Oudit presentation, and I think there'll be a lot of overlapping here from everyone has said before, but I'll try my best not to be repetitive here. So I'm talking about cardiac imaging and biomarkers in the cardiac neuromuscular diseases. I have no disclosures. And imaging the muscular dystrophies related to cardiomyopathy, as have been mentioned, this is a heterogeneous group of rare genetic diseases that often lead to significant weakness due to progressive muscular degeneration. And cardiac manifestations can be not only arrhythmias and conduction abnormalities, but also cardiomyopathy and heart failure. And in some diseases, this can occur as a predominant feature of the disease. So imaging assessment, both with echocardiogram and cardiac MRI, can assess anatomies, global and regional functions, and especially MRI can also look for inflammation, infiltration, and fibrosis. And these can have a potential to identify early disease and improve prediction of long-term outcomes, especially heart failure and arrhythmias. So echocardiogram, of course, has its value, as Dr. Oudit mentioned. It's widely available and very easier to tolerate. However, important to notice that in this particular population, suboptimal images are not uncommon and can be quite a challenge as well. The echo can assess for the LVEF, but sometimes the reduction in left ventricular function may occur late in the disease process. You have the ability to assess strain analysis as well with echo, but also this has issues with the image quality as well. So cardiac MRI does not have issues with the acoustic window. It is the gold standard for assessment of ventricular function and volumes. It can also provide strain analysis, but as well tissue characterization and to assess for inflammation, fibrosis, and fatty infiltration as well. It is, of course, less available. There is an issue with prolonged scan times, and in these populations with patients with scoliosis and respiratory weakness, this can be a challenge for them to lie still for quite a long period of time. Some of these patients also are dependent of ventilator and BiPAP throughout the day as well, so it can be challenging for them to have a scan. And also, if there are arrhythmias, which is often with this population, this can also affect image quality as well. So things, there is a turnaround with that sometimes, but it's just things to be mindful of. So we did publish this paper about the added value of cardiac MRI in muscular dystrophies. And I'll just talk a little bit about like how we can, MRI can add to different types of muscular dystrophies. So these are the most common genes associated with cardiomyopathy in muscular dystrophy diseases. As being said, the DMD gene can lead to different phenotypes such as Duchenne, Becker, and carriers like female carriers that can have isolated cardiomyopathy without any or very mild muscular symptoms. They often have heart failure and cardiomyopathy, although they also can have arrhythmias as well. Myotonic dystrophies, they can affect two different genes, and that will lead to type 1 or type 2. As mentioned, type 1 is a more multisystemic disease with more obvious symptoms than myotonic type 2. The most common cardiac manifestations are arrhythmias and conduction disease in these populations, but they also can have cardiomyopathy and heart failure as well. LMNA gene that can also lead to different phenotypes such as limb-girdle muscular dystrophy, Ehlers-Danlos, dilated cardiomyopathy, and I'll also talk about arrhythmogenic cardiomyopathy later on. And TTN also can lead to different phenotypes, and it's the most common genetic condition that leads to dilated cardiomyopathy. So the dystrophinopathies with the mutation in the DMD gene will lead to an X-linked disorder, primarily affecting males. We know now that it's going to lead to either Duchenne and Becker, depending on the extent of the mutation and the dystrophin abnormalities. So almost like a complete deletion on the Duchenne population. And reduced in Becker's. So the abnormality in dystrophin protein will lead eventually to cardiomyocytes, death, fibrosis, and dysfunction. It is a progressive cardiomyopathy. As I mentioned, the loss of dystrophin will lead to dysfunction, fibrosis, and resulting in cell death. Advanced cardiomyopathy is now the main cause of morbidity and mortality in the majority of Duchenne patients, giving the decrease in the respiratory failure as the major death cause from advances in non-invasive ventilators. So, as mentioned already, also very early on in the disease, you have normal ventricular function, but you can already have some preclinical involvement of the heart, and until later on in the teenager or early adulthood that they will have more end-stage cardiomyopathy and heart failure. So it's important that in this middle range here that MRI can help identify subclinical or early disease as well. And also, as mentioned before, in the Duchenne population, randomized trials have shown the benefit of early initiation of ACE inhibitors in boys that had normal LV function, with slowing down the progression of the disease as well as increasing survival. MRI in this population also showed the presence of LG early on with still normal function. Also, as have been mentioned, steroids are a medication that frequently used in this population that can slow down the progression of muscular symptoms and muscle wasting, as well as the cardiac involvement. So MRI can detect fibrosis before changes in ejection fraction. You can have the ability to assess strain analysis as well, which can even precede the presence of LGE. Most common described, but not the only type, is the subepicardial or mid-myocardial basal inferior and infralateral walls. There's a large single retrospective study with the Duchenne patients that show that LG increases with age, as well with the decrease in LV function. And now that we can also use tools such as T1 mapping and ECV calculation, we can see early diffuse interstitial fibrosis as well in these patients. So this is an example of a Duchenne patient that had, you can see here in the first images already, dilatation of the left ventricle. You can see a subepicardial, infralateral, and mid-myocardial septum wall LGE. You can appreciate just by the color bar here that there is a decrease in longitudinal strain, and there is an increase in the extracellular volume here. Female carriers are at risk for cardiomyopathy. At least 50% of these patients will have one positive finding on MRI. So early surveillance with ECGs and imaging is recommended every 3 to 5 years if there is no abnormality, and of course more frequent if there are symptoms or positive findings. I did have a patient that was a female carrier, came from Montreal. She had an MRI there done when her boy was diagnosed with Duchenne. Her first MRI showed normal function, but already showed LG in the same pattern, infralateral, basal infralateral wall, as described in Duchenne. Then I saw her, it was about 2 years after her first MRI. I repeated the MRI and already showed very mild dysfunction, so I started her on ACE inhibitor. And the MRI in the following year actually showed further decrease in the function. So I think it's also important in a research field here to see if these patients, the female carriers that already have findings, subclinical findings, if they're treated early on as the Duchenne patients, if this can prevent or slow down the progression of the disease as well. Myotonic dystrophies, as have been mentioned, I'm not going to go through that in detail, but it's the most common dystrophy in adulthood. As mentioned, the number of repeats in myotonic type 1 is associated with worsening clinical manifestations, and it's a multisystemic disease. And in myotonic dystrophy type 2, more subtle muscular and cardiac manifestations. Usually more arrhythmias and conduction issues, but it can also have cardiomyopathy and heart failure. Early pacemaker implantation is indicated as per current guidelines, as Dr. Klein, I'm sure, have mentioned. So this is an example of a patient that we imaged at the Heart Institute, a 53-year-old with myotonic dystrophy type 1. He was going for pacemaker, and we did an MRI as a baseline prior to his pacemaker implantation. He didn't have dysfunction on the echo at that point. And we were able to see already presence of subepicardial lateral LGE, as you can appreciate here, and already increase in ECV values as well, and a decrease in the longitudinal and circumferential strain. LMNA-associated cardiomyopathy is a variable myopathy that can lead to different phenotypes. It is associated with dilated cardiomyopathy and heart failure, and is highly associated with malignant ventricular arrhythmias and sudden death. MRI can identify LGE early in the disease, and it has been shown as well that carriers of the LMNA gene has already increased extracellular volume without presence of LGE as well. There have been more research and publications regarding arrhythmogenic cardiomyopathy involving the left ventricle, and some papers now have shown already genes that are associated with arrhythmogenic cardiomyopathy. As you can appreciate here, you can see that LMNA and both TTN are also part of that. It has been also shown that the ring-like type LGE is more associated with the presence of LGE in at least 3 consecutive segments. And as you can appreciate here, a circumferential LGE kind of ring-like type. And this is more associated with the better outcomes in terms of arrhythmias. And it's not related to the amount of LGE, but more of the pattern of the LGE. TTN cardiomyopathies also includes various phenotypes. The primary cardiomyopathy can be associated with core myopathies as well. Truncating TTN variants are most prevalent genetic cause of dilated cardiomyopathy. These patients often present with biventricular dilatation and dysfunction, and they can also have diffuse fibrosis and be more susceptible to ventricular arrhythmias as well. I like to mention about myocarditis in these patients, and also versus like if this is like a hot phase of the disease, just due to the natural progression of the disease course. So this is a publication from the London group with a cohort of over 300 patients that had an MRI assessment for acute myocarditis. So these patients came with chest pain, elevated troponin, and ECG abnormalities. And they tested these pains for various genes, and they were able to see that a proportional of these patients did have genes associated with the dilated cardiomyopathy and arrhythmogenic cardiomyopathy. And you can see here the LMNA and the TTN genes were also present. And this is just an example of these patients that came, and not only late gadolinium enhancement can be appreciated here in this one, actually like a ring type, but also hypointensity in the T2 images compatible with acute edema and inflammation. We also there is also publications regarding myocarditis in Duchenne patients. Childhood, and there have been cases reported with myocarditis in patients after changing steroids or after dropping the dose of the steroids. And also that this myocardial inflammation is a precipitating factor for heart failure, or a marker of progression of the disease. We did have a patient also at the Heart Institute, and I remember discussing that case with Dr. Lougheed as well, of a patient with Duchenne that came in with chest pain, significant elevated troponin compared to his baseline. And we did an MRI that showed acute inflammation, and we decided to increase his steroid for a short period of time. And then after imaging him again with the MRI, the inflammation has improved. So I think also lots to learn about that as well. And as mentioned by Dr. Gavin Oudit as well, troponin as a biomarker in these patients I think there's lots to learn. We know that the CK are already elevated as a baseline in these patients, and as he mentioned, the troponin T is not as specific as the troponin I for these patients with muscular diseases. So I think it's important that we have that in mind when assessing these patients. And perhaps I think more to learn in terms of if these are just myocarditis happening in these patients that have maybe are more prone to have myocarditis with an underlying cardiomyopathy, or this is really like hot phases of the disease itself. And with that, I want to thank you again for inviting me to talk at this conference. I think it's a great initiative, and hopefully I can have added a little bit to that.
And that was an excellent presentation, a really nice overview, very interesting about the imaging characteristics. I think we're actually now on time, and we can start off maybe by seeing if anybody has any questions or comments on any of the topics that were presented by the presenters. And thank you again, all the presenters, for all your hard work and contribution to the discussion.
So I'm talking, yes. I have a few questions, actually. First is for Dr. Oudit. I'm glad that you stayed all the way. Thanks for staying. I really enjoy your talk, Bob. The 3 talks were excellent. But since we're starting a few years ago, we started this clinic. We have so much to learn from you. I'm very happy that you're here.
Glad to be here. Yeah, so I still have another 30 minutes. Absolutely, it's great.
Oh, that's awesome.
Yay.
That's awesome.
Okay.
So no, my first question was very practical, since we have a lot to do in our clinic. What do you do? What do you think we should do as a first step? So far, we're seeing the patients, and we're not seeing the patients the same day together. We don't have any other help in terms of other resources rather than ourselves, to be honest. But we're getting much more patients than we're expecting, and so far we have up to like 180 patients. So at some point we will need to organize it better and maybe have a nurse or a special day for the clinic, because of the follow-ups are getting more and more. So I would like to know your opinion about what should be our next step, and maybe pitfalls that we shouldn't avoid at this level.
Yeah,
Thanks.
Great. Yeah, thanks for the question. Thanks for the compliments, and it's great to talk with you guys and all our brilliant young colleagues. So I think Jane addressed this partly, and so have coffee with your colleagues. That's where you start. So got to get deep down into people's soul, right? You got to connect to them. So I think we're all doing this because we have seen how sick these patients are, how vulnerable they are, and how terrible it is for them to run all over the city and see different docs. It's horrible. And so I think that's your starting point. That's got to get in your head, got to get into your emotional state. There's no sugarcoating this, right? You got to feel that empathy deep down. That's what drives you to do this. So, my workload is double what I normally should. It's on paper. And, this has just been a fabulous clinic we've set up. The colleagues we connect with is just fabulous. We have fun in the clinic, and we learn a lot. I've learned a lot about respirology, right? I mean, you will see stuff that frog breathing, right? I've never seen that before until I saw a patient with end-stage Duchenne muscular dystrophy, where they use the pharyngeal muscle to keep air going into their lungs, right? This is what frogs do. Frogs don't have diaphragms, by the way. So, stuff like that. So at all levels, the parents, one of the things you realize, the burden on the parents, right? Especially mothers. And, Duchenne, right? There's so much guilt, because they pass the gene on to the children, right? And so they live with that for the rest of their lives. We've had so many moms, some of them actually don't want to come to the clinic because it reminds them of their children that they've lost. So, if those are the kinds of stuff gets you going, gets the emotional state ready, and then you just need to find the right people to commit to. Chances are you're going to be doing more than what's on your job description to make this work. And then you just build from there. And so now we have dedicated admin assistant, dedicated nurses. We have an ECG machine. We have rounds. I think one of our colleagues talked about rounds, so noon rounds. So we talked about things, we present patients, we work together, we built a registry, we publish together. And, I'm glad to include you guys as part of that registry. And, we can work together with all of you as in research, but from the care perspective, right? That's the way you're going to need to connect. Talk to your healthcare authorities, right? Your LINs. They should support this, right? Get your patients advocating for you. You didn't hear that from me. Patient advocacy, very, very important. So one of our patient here is actually a son of a famous one of the MPs, and so he has donated a chair, and he's obviously a lot of support from that. So I think getting your patient support, connect with Muscular Dystrophy. Are you connected with Muscular Dystrophy Canada?
Yes, we are.
So reach out to them. I mean, I'm sure Jay knows them well, works with them. Connect with them. Let them come and visit your clinic. They love to do that. Okay, and you get their advocacy, get letters from patients, and send it to your local health authorities. Right? They should be able to support a clinic together with the respirologist, the neurologist, cardiologist, and physiatry is also important. All of the devices and things like that. Social worker, very key, because there's so much support, emotional, financial support that these patients need. So those are the key team members, right? You got to work together as a team. It's actually lots of fun at the end of the day. You're dealing with very sick, vulnerable patients, but you feel good at the end of the day with this clinic. It really gets to you. So so I think that's where you start, right? This kind of stuff you learn as a med student, right? Seeing patients, talking to patients, and I mean that's really the advice I have. And at the end of the day, we bring about change, right? People bring about change, and so I think that's the way you need to see about it. I think Andrew Cron talked a bit about that, right? And how
totally.
how right, and that's where it starts, and then the research comes after that, right? Before you know it, once we start building this national registry, we're gonna have thousands of patients, right? So that will come with time, and we have some funding support and so on. But I think the clinic, you need those colleagues to help you. So the respirology, we haven't talked much, so maybe next year when we do this again, get some respirologists to come and talk about this, because it's more prevalent than heart disease. We can't be egocentric. So it's much more prevalent than heart disease. So they're a big part of that. CPAP, BiPAP, sleep apnea studies, doing the spirometry, all of that we do in the clinic. And so that is also a very, very important part. So you need to get, there is actually someone in Ottawa who's very good at neuromuscular respirologist, I think, that does some of that work. So, get them to come and form a clinic with you. So, and it's all, I think I'm rambling a bit, but you can tell, this has got me going, right? And this is the clinic we started, and we're very close to it, right? So I think you can easily do this in Ottawa. It'll take some work, but you can do this in Ottawa.
I see. Thank you very much. That's actually inspiring to hear you talk about your clinic, and I hope at some point we get any closer to that at least.
Yeah, absolutely. I'm sure you can do it. So, and you've got an excellent pediatric group in Ottawa, right? With the CHEO, excellent genetics, right? One of the top institutions in Canada and in the world. So I think you've got very strong pediatric support. And, I'm sure Jane and colleagues would advocate for your multidisciplinary team. And so we also have, Jane, a transition clinic. So all the peds folks come over to us very smoothly. And so that's also something that's been working very, very well.
That's all. Thanks. Is there any other question? I have a question for Jane too. So I'm not seeing much as an EP. I'm not seeing much patients with defibrillators. Like, is there an indication you guys wait until they grow up, or how come maybe there is not as frequent to see, that they develop the cardiomyopathy as bad as to get a defibrillator. But I don't remember seeing as much patients requiring a defibrillator or even pacemakers.
Yeah, no, that just really is reflecting the spectrum of disease in the pediatric age group. It's quite rare to see arrhythmias and conduction disease in these patients. I mean, in the general pediatric patient population, even if we look at congenital heart disease, it's much less common. But in the neuromuscular patients, very, very uncommon. So yeah, I don't have any current neuromuscular patients with defibrillators, and no one that I'm even questioning that. And maybe over the years, 1 or 2 myotonic dystrophy patients that have required a pacemaker. So it's actually quite unusual, and that's and using biventricular pacing for decreased function, again, because most of our patients don't have decreased function to that severe an extent, because they're transitioning out of our care when they're 18. We just don't have those patients. And I think that's probably similar to other centers. I don't think we're missing a whole bunch of patients. Yeah.
I agree, and this is why one of the many reasons why the transition clinic is so important, that they do connect with Andres and Nina, right? Jane, after they move on to your clinic. So I just want to jump in just one other thing that's available now. I mean, ICD, subcutaneous ICDs, I think might be a good role, because you're not going to put these patients under sedate them, well, much less. And so there may be a rule here for subcutaneous ICDs for patients needing and the pacing stuff for the type myotonics would be different. I think you can't get away with doing the CRT, fancy CRT with the left bundle. But if you need a pure ICD, let's say someone with Duchenne, a subcutaneous ICD might be appropriate. With the caveat that there's a lot of fibrosis here, and I don't know if that compromised the ability of the subcutaneous ICD to prevent, detect and treat ventricular arrhythmias, but it's definitely an option for patients with needing a ICD.
I think Omid is asking whether you do any defibrillator testing with subcutaneous ICD. You don't put in ICDs yourself, right, Gavin?
No. So the other piece is, well, Andres would know, but the other piece is you got to buddy up with your EP colleagues, right? So
yeah,
you have to have,
Sorry, go for it.
Go on, Andres. This is your field.
We actually do it in every case. We stopped doing a DFT test in regular endovascular devices, but we still do it in patients with subcutaneous ICD every time. We actually screen the patient before to see if it's candidate, and I'm guessing that could be a limitation for this population too, with the scoliosis, with the habitus and everything, because T-wave oversensing it's a problem. When we screen the patients, we have tools to screen the patients before we decide if they are a candidate for SICD or not, and we currently test every SICD that we put in the lab.
Yeah, no, absolutely. Scoliosis is a challenge, but their low muscle mass may actually help you may actually help you towards the subcutaneous ICD. So I think it's a really interesting strategy. I think the left bundle pacing is going to be really great for the conduction disease driven cardiomyopathies, basically the myotonic dystrophies.
Yeah, that's brilliant. And I am very glad that you bring it, because I was talking with Dr. Sadek yesterday about this, and we conclude that we should do that for every pacing that we're doing now. It's left bundle pacing. It's happening, and it's going to stay.
Absolutely.
It's definitely something that it's going to be useful for the general population. I think this specific population could be benefit even more.
I'll just make a final comment, and then I have to leave. And so the CRT pacing has been dramatic. I haven't seen such amazing outcomes. And so you know, we had a patient that fully recovered his ejection fraction. I mean, sort of the case that I had presented. It was a guy in his 50s, and so he was a cook, type 1 myotonic dystrophy. So he was having myotonia and weakness, and he was struggling, but his exercise tolerance improved. Ejection fraction normalized. He was able to keep cooking for at least 4 more years. He died, unfortunately, from respiratory problems because he didn't take his COVID. Part of it didn't believe in the COVID vaccine, so it was not vaccinated. He got COVID. Oh my gosh, and muscular dystrophy. So that, by the way, that's part of your multidisciplinary care. COVID vaccination for everybody in this group. Okay, so you don't want them to get any type of pneumonias, right, including COVID. So he died from COVID pneumonia with a normal heart function, right? And so he was one of our first CRT pacing, and we managed to get him on 3 classes of medications after that, and we did fantastic. And so it's real tragic outcome, but you know, he had a really good quality of life and worked full time for an additional 5 years. He was 50 years old when he died. So type 1 myotonic. So
Gavin, I have one question for you before you leave. So what tool do you use? You know, the recommendation, especially for this patient, for example, Duchenne, that NYH is low. And we struggle with that NYH, and they put it in the guidelines still.
No, the guidelines, remember, was written for non-muscular dystrophy patients.
Exactly, so and we're extrapolating this for. Yeah. So an NYH in the patient with in a wheelchair, you know, it's kind of.
How do you do that? How do you examine the JVP in someone in a wheelchair, right? Yeah. How do you assess leg edema in someone with a wheelchair? I mean, they all have edema, right?
Yeah.
I mean, how do you assess renal function in these patients? You're giving them MRA, ACE inhibitors, ARBs. How do you know what's going on with the kidneys? The creatinine is 15, right? Yeah. And it stays 15, and so that's another issue, right? So, you know, it really brings out your clinical acumen. It absolutely pushes you. It pushes you, and if you're the kind of guy that wants to be pushed, guy or girl or lady, whichever, guy being for everyone, but then this is it. This is the patient population that will really push you. You know, using these drugs and being comfortable in knowing what their potassium is going to be, right, without knowing your renal function. JVP, not helpful. Leg edema assessment, they all have mild, sometimes trace peripheral edema. So you're going to have to, so this is where the biomarkers are going to be important.
That's what I was going to ask.
And I think,
risk stratification.
Yeah, the physical exam from a cardiology perspective, not that critical, not that helpful in these patients. New York Heart Association class, throw it out. Doesn't
in a patient without any apparent symptoms, normal LVEF, how do you risk stratify them other than what we know about the ECG, but using LG on MRI and the biomarkers? If you see a certain value, how does that change your management?
Yeah, I start therapies early. So this goes, so that we do another clinic, it's the cardiomyopathy clinic. And so we're seeing now the stage A and stage B, Nina, I think you're getting at the AHA classification. So we start therapies early. I just spoke to a 28-year-old young lady with familial dilated cardiomyopathy, troponin T mutation, very pathogenic. I started on medical therapies, 2 classes. She just did a 100-kilometer hike in Alberta. I mean, this is ridiculous. So, and the heart function is normalized. So I think this concept of early therapy is going to become standard. It's the next big wave, as you know, in heart failure, right? Moving earlier and earlier, you know, which is the base. The big group, much bigger group of patients are those that are earlier on in the disease course. And I think we're going to have to start thinking about early therapies. So I would definitely start early. The biomarkers are important, and we should study that, right? And you know, we need more data, we need more patients for that.
Where do we send the blood work for the? I can't remember the biomarker.
Your lab will have to. Oh yeah, so your clinical lab should have the BNP. And
yeah, definitely BNP troponin, but your biomarker, the biomarker that starts with a T, I forgot what it's called.
Oh, tenacin C. You can buy kits for those. So yeah, we're working with the folks in Austria on that. So hopefully to have that submitted soon. It's a massive study, and you know, they came to us and asked us for biomarkers, FYI, and they did all this beautiful work, cell work, molecular work, animal model work, and our biomarkers were super positive. So they're very happy. We're just trying to wrap it up together, right? So to speak to collaborations and connecting with people, right? So
Absolutely.
I think we'll be able to do that locally. So yeah, so anyways, the biomarkers, the troponin I works, the troponin T, and I did propose that as a question, less useful. And so, you know, anyways, it may be that the skeletal muscle is starting to regenerate and is making troponin T.
Oh, that's interesting.
It's cross-reacting, yeah. So I think it's less useful, but the troponin I is more most helpful and definitely prognostic. So that's as you know, skeletal muscle regenerates, and you know it fails ultimately in these patients, but there is some muscle regeneration there. So, but it'd be nice to study this in a much bigger cohort, of course, with you know including all of you here. So, so
it's a nice pearl.
Yeah.
Sorry, I keep going. I will keep going. You let us know when you have to leave, Doctor.
In 5 minutes.
So, and this is maybe for Dr. Lamacie too. It's we're using MRI also for myotonic dystrophy patient. Actually,
yes.
But I'm not sure if how useful it's going to be. In terms
it's very useful. So surprise finding, no fibrosis, reduced ejection fraction in the left bundle, small hearts. So no one answered my question. So the other question I proposed, why are the hearts smaller? So it's not, so anyways, we dug back in the literature. So it turns out the DMPK gene is important for muscle growth. Muscle growth. So they get small muscles, skeletal, and also heart. The heart doesn't grow. So it's down by about 30%. And it's not because of atrophy from lack of exercise. You know, you would have seen that in the Duchenne, right? Because these patients are still fairly active, right? And so they're in the 50s and 60s. You know, they don't, use of ambulatory aids is you know, lower on the list. So it's not a physical inactivity issue, right? But the reduced LV mass is very, very impressive. First time we've seen it, first time I think documented with MRI. So, and there's some beautiful work decades ago with human muscles, stem cells, and animal models showing that they have reduced growth, striated muscle growth with this the myotonic mutation. So very interesting. And I think that it makes them more susceptible in terms of less muscle means lower stroke volume, and they're more susceptible to any heart disease, right? Including conduction diseases, related cardiomyopathy.
And in terms of follow-up, if you do one MRI in a patient with some conduction disease and it's normal, for example, the case that I presented, I was waiting for some LGE or something. The guy was, the EF was 25-30%, although he was in a flutter. We ablated the flutter. He was in sinus, but the MRI was completely normal. No LGE.
Yes.
Completely normal.
It very different from a Duchenne. Fibrosis all over the place. So
yeah.
So yeah, no, that was a great case you presented. I sent you guys. We published a cohort of Emery Dreyfus. They're very sick patient. And by the way, the anticoagulation for these patients, I would anticoagulate them. I would throw out the CHEO VAS score. Never studied
even with a normal EF.
Absolutely.
Okay.
Because one of the things you realize is this atrial myopathy,
right.
Atrial standstill and variants of it. And I think in both the Lamin, we've seen this in the Lamin cases, atrial myopathy precedes the global myopathy, ventricular dysfunction. So be very careful about that. And was
your patient anticoagulated before, like, because it's a flutter was there for a long time, Andres. Was he anticoagulated when he came to you?
No, this was a myotonic dystrophy patient anyway. It wasn't a Lamin. It wasn't a
Dreyfus, yeah.
Okay.
Yeah. So
I would have low threshold for, and you know how safe this stuff is now, right?
Yeah, no, definitely. It's a different game with the dog, like just putting it. And the risk of bleeding is still low if the patient is young and could be frail too. But muscular dystrophy patients I think they are not at higher risk of leading in terms of
Yeah, no, it's a fascinating group of patients, and it's great to see you guys also excited about it. It's great to work with you, our PEDS colleagues, our colleagues from New Zealand, and to build up our registry. The other fascinating thing about these guys, and I'll shut up and go to my hockey tournament. They don't get. Has anyone seen PE in this cohort?
No, but I've read about how they die from it. Right? Can they? Or no, they don't. Oh, okay.
We don't see it. We don't see it. So,
okay.
In medicine, we put DVT prophylaxis in everyone in the ward. The data for that is very lousy. And in fact, the recent New England paper challenged that aspirin is as good as DVT prophylaxis. I don't use DVT prophylaxis in hospitalized patients. I think it's a bit of a sham. Maybe in a small subgroup of high-risk patients, but these patients have shown us that you can be in a wheelchair, you can be there for decades of your life, and you don't show up in massive PEs on a monthly basis. And there's something there that's different about these patients, and it does tell us a lot. It's humiliating to our knowledge, and it's a privilege to be taking care of these patients because you learn so much. That's something else I've learned about these patients, that this whole business about being immobile, precipitating DVT and PEs, I don't know about that. There's a lot more to it than that, right? This is a group of patients you would have seen the highest prevalence of DVT and PE. You do not see that. We've seen 500 patients in our clinic. I think I've seen DVT once, right? So anyways, it's another big learning point with these patients. So.
Yeah, that's a very good point. It should be very often.
Yes.
Yeah, I read that. I read that too, but I think it was more an explanation for the sudden cardiac death rather than the real cause. No, because the sudden cardiac
death is because we can't diagnose. We didn't diagnose their subclinical.
Exactly.
Yeah, like VT in the type 1 myotonic dystrophy.
We don't know if it's VT. Yeah, exactly, or aspiration, or like hypoxia, and
aspiration is a big issue. Absolutely, the
go into the same category, like it's sudden cardiac death.
Wonderful, guys.
To your point, there, Andres, because you asked, and I'm really sorry I can't manage my video here. It doesn't allow me.
Yeah.
Just to say that you asked about the MRI on these myotonic dystrophy patients, and I do think that, of course, we have still a lot to learn. As Gavin mentioned, I think that for that patient I showed in particular, he already had fibrosis, he already had increase in ECV, and the question is like, should we put in these patients early on therapy, as we have data with Duchenne, but we don't have with these patients yet. So I think it's important to continue to gather this data and work in collaboration with other centers, of course, so we can reach to that point. But I think that's where we are heading towards.
Yeah, no, absolutely. I totally agree, guys. My favorite drug, one of my favorite drug of all times, is mineralocorticoid receptor antagonists. I think they're so wonderful drugs, the anti-remodeling effect, anti-fibrotic effect, anti-arrhythmic effect. And so I definitely start therapies early. So, yeah.
Agree.
Hey guys, have a great
evening. I think we're in time. Thank you very much. I couldn't thank you more for being here.
The privilege is all mine. The privilege is all mine. Thank you, guys. You're wonderful.
It was an excellent first session. I hope you guys can join next year too.
Absolutely. Okay, take care.